So I know Sundays are hard for everybody to come, so I appreciate it. And we have an awesome team of neurologists here today that I am just so grateful to Dr. Tony DeMarcita. She is an incredible doctor, an incredible leader, and somebody that I met a couple of years ago who really inspired me. I found she was doing a branded talk for us during COVID, and I found out that she was a ballroom dancer. And anybody who is a dancer, I go, whoa, we are soul sisters. And we are. What happened was, she has the biggest heart, and she really became a supporter of us. We have an amazing PWP workout program, and she did one of our webinars where she introduced all of our teachers, all of our instructors. And she has sent patients to us because all of our workout programs are over Zoom. So she's one of the few doctors that understands that that realizes and knows that we have an amazing workout program and recommends our program to her patients. I'd like to invite all the neurologists to come sit down on this wonderful stage. Are we all ready to go? Are all the USPs lined up? Okay. And don't be bashful, doctors. I am super grateful to Dr. DeMarcita for bringing her whole team, who is giving us their Sunday, and the topics that we're talking about will touch every one of you. Before smile. We need smiles from everybody. This is what these events are about. It's about understanding that there's a lot you can do about with Parkinson's. And you're going to hear that from the doctors today. And before the doctors speak, I want to introduce a very good friend of mine, Dr. Phil Schneider. Dr. Schneider is a speech language pathologist for over 40 years. He's been working in New York in the field of stuttering. And he became very, what do I want to say? He got to know Parkinson's very well himself. So he's been living with Parkinson's for a couple of years. And before we start with the doctors, I'd like to bring up Dr. Schneider to come in and say a few words.
To quote my favorite rabbi, Dr. Rabbi Advice, I'm up here talking to myself, and I'm letting you listen. So Sue asked me to share a few words to open this up. I think what would be meaningful to me, potentially meaningful to you, is that brought me to the issue of linearity and non-linearity. That as human beings, we have this strange sense that we know who we are, because we knew who we were yesterday, what we were capable of, how our bodies work, how our personalities worked, how things worked. And we expected it to be the same way today and tomorrow. And the reality of the world is nothing stays the same. Certainly the presence of Parkinson's ramps that up. It turns the ups and downs into more of a roller coaster ride. And then it brings another quote, which is that we are not human beings, we are human becomings. And so this condition or challenge we call Parkinson's means we constantly have to know what's happening and adapt. In the program today, and the people who are coming and gifting us with their time and their expertise open us up and expand us, that there are lots of different things to do to adapt to the different circumstances in our lives. And it never becomes static, you never cooked, you never done, you find the right medication that seems to be helpful. And it was working beautifully for a while. And you can count on the fact that at some point, it's not going to be, you're not going to be as happy with it. And you have to consider something has to change again. So it can make your life very dynamic. And share a few of those experiences from myself. I developed a routine of walking with walking sticks because I felt unstable without them. And then I discovered that if I walked faster and moved my arms more, not only did I start to feel more and more, I started to feel elevated emotionally, and I started to notice that I needed less medication to control some of my tremors and other disquieting things I was dealing with. And then I went like, if that's really true, let's try some music, because at one of these meetings I heard about how music can help. So I got headphones and I started listening to high energy music, Irish dance music, Jewish celebration music, and I started to be able to skip and dance with the walking sticks going through the woods in my neighborhood. And then about a year ago, I developed severe pain in my hip. And, I couldn't stand, and I started to, so I tried using a walker. On a few occasions I used a wheelchair. And about 6 months of that, I decided to consider medical intervention. I tried, injections, and then I was scheduled for surgery to remove a small tumor that was on my spine. And before that, my son, who's interested in chronic pain as an issue, said to me, what about going away to relax for a while, like relaxation? And also, have you considered an osteopath? I go, I don't even know what an osteopath is, but I wouldn't go to one. And then I heard some good things about somebody who had that label. I went for 3 visits to this osteopath, and then I went away for a few days to hang out in the woods. And 3 days into that, I became free of the pain medication and canceled the surgery. So, I mean, you never know. The point is that stability and everything stays the same is just not the truth. Things change. You get things you didn't want, you lose things that you thought things, one day I can't tie my shoes, another day I can, but I can't button my shirt. Sometimes I stand up and I drool, and sometimes I don't. And it's constantly changing. And so realizing that there are always more things to explore is very, very helpful. And then there's the process of talking to people, like being here talking to each other. When you share your story and its details and some of the inner pain and struggles, emotions, and someone listens who really cares about you and maybe has some insight into this condition, but the listening, when they listen and they want to know more about what you're experiencing, as you try to explain it to them, guess what? You get to know yourself better. That's how psychotherapy works. The therapists just go, but you get to hear and know yourself better. And as you know yourself better, you start to notice all the different things you might shift. Hydration, diet, sleep, rest, exercise, and beyond that. Managing anxiety and stress. I went back and decided after 52 years of marriage that we could benefit from some marriage counseling. And it's been miraculous. The lower my stress, the better I handle my Parkinson's. There's one more dynamic that I want to share, which is the dynamic between self-acceptance and self-adjustment. Sometimes it's best for me to say, look, right now, I just can't do any better. This is where I am. And I'm grateful for that. And sometimes I say, you know what? I got to kick it into gear. I need somebody else to encourage me and push me forward. So I went from one type of physical activity, and now I have a dear friend here who we're playing ping pong together. It's a new joy. Started out as a therapeutic activity in my mind and my buddy Arnie's mind. And I think now, I can speak for myself, I think for Arnie, that we're having a good time with it. All we want to do is a little bit more of it. So sometimes taking on the challenge leads to something really good. But there's a balance between acceptance and adjusting. And I hope that today increases our awareness that there are many things that we can still do to improve the quality of our lives, sometimes even just a nap. So I'm glad you're all here, and we are here to support each other and encourage each other, knowing that we're perfectly imperfect. Plenty of room to get more perfect. So let's go.
Thank you, Susan, for the gracious words earlier. But truly, I have had a few opportunities at this point to interact with this group. I am Dr. Tony Demarcaida. I'm the medical director of the Chase Family Movement Disorder Center. What I was so excited to do for you here in Suffern and Pomona, New York, was to bring the expertise of this amazing, amazing group of people that we call our team. At Hartford Healthcare's Chase Family Movement Disorder Center, we have some of the most passionate, compassionate, expert, and skilled neurologists and neuropsychiatrists caring for people with Parkinson's disease. I really wanted this whole conference to be more like a conversation. So you're going to see rapid fire information. You're going to hear rapid fire information about as much as we can share with you about Parkinson's disease. Because knowledge is power, right? And who you're going to hear from are really the most respected physicians in Connecticut, in the region, in the field of Parkinson's disease. I am so proud to introduce to you Dr. Michelle D'Agostino, who will be speaking about sleep. Dr. Marissa Moller-Casillas, who will be speaking about skin and bones. Dr. Dorfman, who will be speaking about mood, memory, and psychosis. Dr. Bortan, who will be speaking about levodopa, the gold standard of care in treatment of Parkinson's. Dr. Jim Duffy, who will be speaking about breathing as a new science for an ancient remedy. Dr. Larman will be joining us shortly. He will be talking about nutrition. Dr. Mayton will be talking about exercise and Parkinson's. Dr. Machado will be talking about the gut-brain connection and the microbiome role in Parkinson's disease. And I will be talking about the Parkinson's journey as we partner with you today in commemorating April as Parkinson's Awareness Month. Welcome to the Hartford Healthcare Chase Family Movement Center.
Dr. Michelle D'Agostino, it's nice to meet you all. Thank you for coming. Get ready, we're turning on the hose. So we have a lot of information for you. So my topic today is Parkinson's and sleep. I've been doing this for about 20 years, and I don't think there's one patient I've taken care of in my career who hasn't had at some point a problem with their sleep. And I also have a family member with Parkinson's, and that has been quite a challenge for her as well. So I'm going to try. I'm going to try and get these for you as quickly and tolerably as possible. I have no financial disclosures. So let's just jump right into it. I pared it down to about 3 of the most common sleep disorders that we see in Parkinson's, because certainly we see more than 3, but I could spend a day talking about this. Insomnia and excessive daytime somnolence, or being tired, is one of the most common that we see in the disorder. We also see a lot of REM behavior disorder, and then a lot of restless leg. So I think we don't do a great job in educating our patients about sleep in general. We tell you to get more sleep, but we don't tell you how, and we don't teach you about it in a way that sometimes helps you make sense of it. To keep it a high-level overview, there are 4 stages of sleep. You cycle through them all night long. So it's not one linear progression all night. You cycle through them all night long, right? And the first stage is your very light sleep. Not much is going on. Stage 2 is where we really start to see changes in brain waves, in the patterns. And so with the reason why this is important to understand is that stage 2, you start getting into some repair, you start getting into some areas where the body is consolidating memory, but it's really not until stage 3 where we really start to see that immune response boost. You see that rapid eye movement period, which we're going to be talking about in a minute. But this doesn't occur until about 90 minutes into your sleep. Why is this important? Because this is the area we really want to get into. This is our deep sleep. And so if you go to bed and you're waking up to go to the bathroom every hour, or you roll over and you're uncomfortable and you're waking up for whatever reason every 80 minutes or so, you're never going to get into REM sleep. You need this to consolidate your memory, to keep your immune system robust. And so when we're sort of working with you on your sleep patterns, it is important for us to kind of understand that and to know that as the night goes on, those REM periods get longer and longer. Some of the other periods get shorter and shorter. So stage 2, you basically spend about half of your night in it, but it happens more towards the morning, right? It's important to know this because again, when you get into stage 3, that's when we start noticing real problems with maintaining sleep. Stage 4, so you're cycling back. I'm just not going to use my slides. Oh, okay. Okay, and then stage 4 is our REM stage, right? We're the most active. What's interesting here, and couples usually tend to enjoy this, is that your brain is actually more active in stage 4 than during a conversation with your spouse. So if you put the leads on people's brains when we're talking to our spouses long term, you kind of get into these patterns where you're not as active. You can kind of you can tell what the other person's going to say. You can finish each other's sentences. Stage 4, right? And this, you have to be in these stages. You have to complete all 1, 2, 3 to get into 4. If you don't do all this, you're not getting into the part that really matters. So let's just move right into insomnia and excessive daytime sleepiness. So insomnia, when you want to go to bed and you can't, right? It's take your time at night. You decided you want to go to bed. Some people have taken additional medications before sleep, some haven't. You get into bed and now your brain starts to try and solve the problems of the world. You cannot get comfortable. You run the same scenarios over and over and over again, and you sit there and you get more and more anxious that you're not going to be able to fall asleep. And now you've got to go to the bathroom, so now you're totally disrupted and you've got to get up and you've got to go. The other thing that people without Parkinson's and people who do not work with people with Parkinson's, what they don't understand is the excessive sleepiness. People will say, oh, I understand you're tired. They don't understand. Excessive sleepiness in Parkinson's is very different. It's different because when you go to sleep, you're not recharging completely the way you used to 10, 20, 30 years ago. It's almost like being on a trickle charger. If you've ever plugged your phone in and you're not all the way and you're not really recharging, you're fighting your body during the daytime, right? And you don't think about it because it comes on so subtly. But usually with Parkinson's, in typical idiopathic disease, 1/2 of the body is affected before the other, right? And so there's this slight gap or this slight delay that you're coping with all day long. And if it happened for a half an hour at a time, it wouldn't be that big of a deal. But you're dealing with it 24 hours a day, all day long, every day for years on end, and it's exhausting. You don't have the same neurochemicals that you had 20 years ago. You don't have as much dopamine for your motivation pathway and your reward pathway. So it's exhausting. So the sleepiness, I love the quotes, between 21 and 75% of people, I would say 100, right? In my experience, I don't think I've ever met someone with Parkinson's who has come in year after year, visit after visit, and said, I feel amazing, I have so much energy, I just can't figure out what to do with my energy. Someone at some point, I think it's 100% are tired. And again, like I mentioned, part of it has to do with the Parkinson's. When you don't have enough dopamine, it's very difficult to let movements go through that you want. And it is very difficult to stop movements that you don't want, right? And so that rigidity that you always hear us talking about, that stiffness, that slowness, that little bit of disconnect for your brain is difficult to interpret. It can feel like weakness. It can feel like heaviness. It can feel like you're moving through quicksand. It's very difficult to move. And the disconnect is exhausting, right? Because it's not just getting up and trying to go to exercise. It's not just that you don't have that dopamine to incite you to want to get up and do things. It's that the whole time once you're there, you could potentially have a wave of fatigue come over you out of nowhere just from the disease. And you can do everything right and take all your meds on time and be properly hydrated and have a terrible time. You can do everything wrong and have a wonderful time. And the disease is very unpredictable, which is quite frankly exhausting. And then if you look at the package insert on every single medication that we have to give you, they all say fatigue, right? Every single one of them. So sometimes we have to adjust on our end as well. So the next thing I want to talk about is REM behavior disorder. So REM behavior disorder occurs during REM sleep. REM sleep is the rapid eye movement sleep that occurs, as I mentioned before, in stage 4 of sleep. What happens here typically has been happening for probably about a decade or more in your life prior to being diagnosed. You talk in your sleep, you act out your dreams, you may mumble a little bit, or you may have full conversations. It's difficult to say and they kind of come and go. But a lot of times people will say, oh, he or she, oh, they've done that their whole life. It can be as subtle as whimpering. It can be as involved as I had a patient who would routinely dream that he was at a grocery store thumping a melon to check if it was right. Unfortunately for his wife, it was her head. Right? So you can have people that don't move very well during the daytime who at night, because of this different pathway, are able to actually get out of bed, rip off a headboard, throw themselves out of bed. And so there's a very high incidence of people getting hurt, which is why we care about it. Now you're more likely to have a problem with REM behavior disorder as the night goes on if you're someone who is actually getting a good night's sleep. And so you're going through these cycles, as I sort of mentioned, right? Because they're getting longer as the night goes on. And for the most part, there are several ways to treat this. If you're having mild REM behavior disorder and your bed partner does not mind, we keep you in the same room and we do not medicate you, right? If you're sort of mumbling and it's not disruptive, we're not going to do anything with that. We're going to make sure that your bedside table is safe, you know? You're not going to have sharp objects, you're not going to have things near you where you can get hurt. But we typically will be very conservative with those measures, knowing that we want to pay attention. The patient doesn't know they're making the movements. You don't know that you're doing it. And so it's very difficult for people because if you hurt your bed partner or yourself, there will be times where people feel terribly guilty and I'll say to them, it's not your fault. No more could you be 10 feet tall than you could have stopped yourself from having the REM behavior disorder, right? You can't predict it. And at times, again, as I said, sometimes up to 80% of people will have an injury in the course of their REM behavior disorder throughout the course of their disease. And so we do at times need to actually medicate this. The number one way that we medicate it actually is with an over-the-counter medication called melatonin. Melatonin is something that your brain is making anyway. Melatonin is not meant to knock you out, right? And so I think it's misused and misunderstood because you typically are aware of it in the context of I've been traveling, my time zones are off, I'm going to take a low dose of it 1 or 2 times, I'm going to get back onto my schedule, and then I'm going to be fine. Melatonin in the world of Parkinson's is actually quite different. We have to use higher doses. So as opposed to someone who does not have Parkinson's who might be using 1 to 3 milligrams, in our world there are papers suggesting the use of up to 50. Now, most of us don't go that high, right? Less is always more, but I never start typically lower than 5 milligrams, right? And because we know that REM behavior disorder is worse later in the night or earlier towards the morning, short acting typically does not do the trick, right? So if you're someone who's acting out your dreams or potentially hurting yourself at 4 a.m., taking a dose at 8 p.m. is not going to stop that. So it comes in a pill form that has 2 layers. It's a bi-layer pill, and it's over the counter. It usually comes in 5 milligrams, and we sort of titrate up. And the trick with melatonin really is what you want to do is take it at the same time every night for at least 2 weeks. Because what you're trying to do with it is you're trying to send the signal to your body that it is time to go to sleep, right? It's not meant to knock you out. What's supposed to happen biologically before invention of all the lights and the slides and the screens is that the sun goes down. And as the sun goes down, the back of your brain says, okay, it's time to go to sleep. We're done milking the cows, and it secretes the chemical, and it's the rise. It's the rise of that chemical that does the work. That's what tells your body it's time to go to sleep. And so most frequently, when I see a melatonin failure in our REM behavior disorder patients or our insomnia patients, it's because you've tried it a couple of times and it didn't work. So I think it's really important to sort of clarify our definition of work. And work means that after 2 to 4 weeks, you're falling asleep more easily, but again, you're not knocked out. I don't want it to, when you get to go to the bathroom, you're stumbling all over the place and you're gonna fall and hurt yourself. That's not our goal. It's that you're more easily able to shut your brain off and go to sleep, right? And then you're not acting out your dreams and you're not talking in your sleep later in the night. The other gold standard that is actually a prescription is a medication called clonazepam. Now, clonazepam or Klonopin is a long-acting sedative. The reason we use that one is because short-acting medications that sedate you tend to have people need more of them, and people get sort of used to them, and they can't go without them, right? We don't want to create dependence, right? Clonazepam is used because it has a very slow, gradual build and a very slow off. So just like everything else, we're trying not to shock your system. I don't want you to peak and crash. It's uncomfortable. So the clonazepam is the prescription gold standard, and we will use that in people who have gotten hurt, right? So if you're someone who comes in and you have fallen out of your bed, I don't need you breaking a hip, a shoulder, cracking your head. That is someone who I would skip the melatonin probably and go straight to clonazepam. Again, it's a conversation you want to have with your clinician, but you definitely want to share this behavior with your clinician. And the other thing is, even if you're not hurting yourself, if you're disrupting your bed partner to the extent that they have to leave the room, and you don't want them to leave the room, you might want them to, but if you don't want them to leave the room, please share that with us, because we can fix it. You know, that's an important part of a relationship to some people, and if it's something that you value, we respect that, and we can work with you. So don't think that that is something that you shouldn't bring up or shouldn't try to improve upon. So the next topic in my deck was restless leg syndrome. And this is very interesting when it comes to Parkinson's, because typically restless legs, it runs in the family. We tend to see this with Parkinson's quite a bit. The definition is that it's an internal sensation of needing to move your lower extremities. So typically when you lay down, when you sit down, when you rest, and it's described in a number of ways: itching, picking, pulling, creeping. I mean, I've heard any variety of explanations. And it only gets better when you get up and you move. And we know things like caffeine, we know alcohol make it worse. We know that if you're sleep deprived, right, catch-22, if you're tired, it gets worse. What makes it better a lot of times is addressing the sensory component to the legs. So if you've got neuropathy, kind of nerve damage or nerve pain in your legs, that tends to trigger this sort of cycle within the body of discomfort. And once you kind of get into the cycle, the only way you're going to stop it is like rebooting your computer. You've got to get up and you've got to move and you've got to walk, right? And it's important because this is terribly disruptive. It makes it so you can't go visit your family. You can't sit at a show. You can't go out to dinner. You can't make plans. And anyone in this room who's ever had restless legs, you know it's the one condition you can't fall asleep and escape. So it can be very challenging, right? So with this, with restless leg syndrome, we try and address the underlying cause. A lot of times it's as simple as a vitamin deficiency or an iron deficiency. We check specifically ferritin. And that's a rough thing to sell people with Parkinson's, because everybody with Parkinson's for the most part is constipated. Oral iron is very constipating. Slow iron tends not to be, and iron infusions can be very, very helpful and replete you in a very quick period of time rather than 3 to 6 months while you suffer. We also will do weighted blankets, compression type items, topical creams, and even botulinum toxin injections to the limbs to, again, address the sensory component. Got about 4 minutes left, and what I want to focus on is sleep hygiene. It is underrated, and it really is the star of sleep. So I'm just gonna go through it with you very briefly. In a perfect world, and we're not perfect, you ideally do not want to have screens in front of your face for about 2 hours before you go to bed. And again, that's because the back of your brain is getting this light signaling it's time to get up and milk the cows. You get very excited, your adrenaline starts going, your cortisol rushes. It's very confusing for your body. So you don't want to have the screens if you can avoid them. You don't want to be watching programs about serial killers right before you go to bed, because again, that can be very disruptive to your sleep. When you do go to bed, you want to keep on schedule. Now, many people that I take care of are retired and you've worked your whole lives and you don't want to be on schedule. I appreciate that. But if you want to be able to fall asleep, the best thing you can do for yourself, especially if you're dealing with insomnia, is if you set that alarm in the morning for the same time. Going to bed can be tricky. You're not always in control of what time you go to sleep, but you can control what time you get up. So if you get up every day at the same time, whether that's 6 a.m. or 10 a.m., it doesn't matter. You minimize your daytime naps. You try and stay awake, and you will find that gradually you will be going to bed and your body will learn, this is the time I go to sleep, this is the time I wake up. And when you go into your room, that room needs to be dark, it needs to be cool, it cannot be cluttered, you cannot lay in your bed and solve the problems of the world. So if you're in there and you have the mobility to do so, ideally you do not want to stay in that bed for longer than 30 minutes, because if you stay in that bed more than 30 minutes, over and over and over again, what you have taught yourself is that this is where you go to worry. And as soon as you get there, your brain, whether you realize it or not, is going to tell you this is where we go to be uncomfortable, this is where we go to worry. You don't want to do that. So if you're mobile, you get out of bed, you go do something very boring, whether it's read a book, listen to quiet music, just peacefully do something. Again, if you can. You want to get daylight first thing in the morning if you're able to. Not everyone can get out of their home, but there are light boxes that you can order, because again, you want that signal to come in, but it takes months to really establish this routine. And I find that most people, by the time you mention that you can't sleep or you're not getting a good night's sleep, you're exhausted, you want an answer yesterday, right? The problem is that if I throw medications at you to knock you out, instead of actually taking care of the underlying problem, it's like putting a Band-Aid on something that needs stitches. And ultimately, I'm going to over-medicate you. You're going to be groggy in the morning with this medication hangover, and you potentially are going to have a difficult time getting up and going to the bathroom. So I'm going to wrap up there. I apologize if my slides couldn't be shown. And I believe we're going to have time for questions later, right, Tony?
Right. No, we'll do it later.
Okay. Thank you.
Hear me well? My name is Marisa Mora de Casillas. I'm a member of the movement disorder specialist with Hartford Healthcare. How about now?
Yeah.
Yes. So before we start, I would like to ask you to please raise your hands about how many of you, when you think or hear Parkinson's disease, you think about skin and bones. So I'm very, very excited about this, because then I hope you get a new piece of information to the puzzle of Parkinson's disease. So why is this important? Well, skin is the largest organ in our body, and it actually, well, as you know, covers our entire body from head to toe. And the skin has many, many functions that are vital to our survival. So it protects against heat, light, injury, and infection. It regulates the body temperature. It helps us store water and fat. It is a sensory organ. It's through the skin that we are able to touch and sense. It prevents us from water loss. And it also, it's kind of the organ that makes up or help us make up vitamin D. So it is a very highly active organ in our bodies. Just a brief summary of what is the anatomy of the skin. So the skin could be major layers. The more superficial layer is called the epidermis, and that's where we have two major different cells. But for the purpose of this lecture, I want you to remember that in the epidermis lay the melanocytes. Those are the cells that provide Can you hear me? Yeah. I don't feel like attached to the point. So the melanocytes are the cells that provide and impart the tone to our skin, hair, and all our colors. The second layer is the dermis, and this is the layer where you have all of your blood vessels, a lot of nerves, and tissue. This is a very highly sensitive, where all our major vessels and nerves reside. And then you have the deepest layer, I should say, that is the hypodermis. That is where it contains a lot of our fat tissue. So remember, 3 layers: epidermis, dermis, and hypodermis. Skin disorders are very important in patients that have Parkinson's disease, and frequently are under-recognized, or a lot of people don't even know that you need to worry about your skin if you have Parkinson's. There are several skin conditions that are very prevalent or more prevalent in patients that have Parkinson's disease than other healthy subjects. And these are the ones that I want you to remember. The first one and most important one is melanoma. Melanoma is a skin cancer. We'll talk about it, and it is significantly increased in patients that suffer Parkinson's disease. There are other non-cancerous conditions that are mostly inflammatory, including seborrheic dermatitis, sweating dysfunction, pemphigoid, and rosacea. So let's talk about melanoma and Parkinson's disease. So melanoma is a form of skin cancer, and it arises from the melanocytes. You remember we pointed out to you in the epidermis, we have the melanocytes which provide the pigment to our skin. Unfortunately, melanoma is the most aggressive and treatment-resistant skin cancer. And the diagnosis of melanoma, let's say the majority of the melanoma are or can be easily suspected on visual inspection. And you have to look for several things. You have to look for an asymmetric lesion. Usually the borders of this lesion are irregular, as you can see on the diagram here, in the picture. The color varies. Usually the lesion has different type of colors within the same lesion. They are usually larger abnormality or skin lesions, and they evolve over time. They may change in their color, they may change in the size. So all of those are, if anybody has a skin lesion and they have any of these characteristics, it's imperative that you see a dermatologist. There are actually unique epidemiological and molecular connections between Parkinson's disease and melanoma. There is a lot of research, very intrinsic science behind all of this that I'm not going to bore you with. But what we do know is that patients that have Parkinson's disease have a 1.4 to 20-fold increased risk of developing melanoma. And there has been a lot of controversy in the literature across the years about, can this be due to the dopaminergic medications like levodopa? And actually, most of the evidence shows that it is not associated with treatment for Parkinson's. The incidence of levodopa is the incidence of melanoma is actually higher even before a person receives any type of medication for Parkinson's disease. So there is an inherently relationship between melanoma and Parkinson's that coexist in the same person, not directed to the medication that we use for the treatment of Parkinson's. Interestingly also is that patients with melanoma are at increased risk to develop Parkinson's disease. So if a person has melanoma, they are 4.2-fold increased risk of developing Parkinson's disease. So again, there is this intrinsic relationship between these two conditions. How about other skin cancers? So fortunately, melanoma is not the most common skin cancer. There are two non-melanoma skin cancers that are very common. One is called basal cell carcinoma, the other squamous cell carcinoma. The most common type of skin cancer in the general population is basal cell carcinoma, and actually account for for 17%, 75% of the skin cancers in the general population. We know that similar to melanoma, in patients that have Parkinson's disease, they have a significant higher risk of basal cell carcinomas and a smaller increased risk of squamous cell carcinomas. On the images on the bottom, to the right of the screen, there is a patient who has a basal cell carcinoma, and on the photograph to the left is a squamous cell carcinoma, just so to get an idea of how these lesions look. The most common risk factor to develop these two types of skin cancer is ultraviolet radiation, so sun exposure. It's for everyone. So we should use our sunblocks because if not, we're putting ourselves at risk for these two skin cancers. How about other conditions that are non-cancerous? So there is a variety of other skin conditions that are more common in Parkinson's disease. But let's start with seborrheic dermatitis. That is an inflammatory / infection of the skin, and usually affects mainly the face and the neck. As you can see on the image on the right, that's a pretty typical looking image for seborrheic dermatitis. Patients with Parkinson's disease also have sweating disorders. The most commonly patients experience excessive sweating, and frequently this is seen when their medications are not working well. So they usually experience sweating, drenching sweats in the off periods. Frequently we see this overnight. So the way we first treat this excessive sweating is by addressing the dopaminergic medication, so patients have less of these off periods. There are other two conditions that are commonly seen or more commonly seen in patients with Parkinson's disease. One is called bullous pemphigoid, and that's, as you can see, these red patches in the skin associated with raised bullae. And the other one is called rosacea, and these are patches of erythema, particularly around the nose and the cheeks. Both of these conditions are have complex mechanisms of behind them, and they are usually treated either with topical steroids, or sometimes if the disease is very severe, with oral systemic immune agents. So my message for you after these few slides is that there are frequent conditions that are seen more common in patients that suffer Parkinson's disease, and that if you are or your loved one is diagnosed with Parkinson's disease, it's imperative that you see a dermatologist on a yearly basis. I find, I don't know if my colleagues have found the same thing, but I often find resistance from the dermatologist fighting me about this, like why are you referring the patient? Well, just I show them the literature. My patients are higher risk for developing all these conditions. The second brief topic I want to talk to you about, moving from skin to the bone, is that osteoporosis is a problem in our country, and the older our population gets, the higher the risk of osteopenia and osteoporosis. So osteoporosis is characterized by low bone mass and kind of deterioration of the bone microarchitecture. And this leads to an increased risk of fractures. As you can see on the picture on the corner, you can see a healthy bone, and on the other side, a bone that has osteoporosis. The bone has lost its structure, and it has become depleted of minerals like calcium, for example. Frequently, we can test or assess for osteopenia and osteoporosis by a test called the bone mineral density. And this test measures your calcium and other minerals in the bone. Bones that are healthy contain more minerals and tend to be dense versus bones that became osteopenic. They lose calcium, they lose the structure, and they are more prone to break. And bones become less dense naturally as we get older, or if we develop certain medical conditions such as Parkinson's disease. So we know that patients that have Parkinson's disease have a higher rate of osteoporosis and bone mineral density loss. And this is particularly evident in 3 parts of the body: the hip, your lower back or your lumbosacral spine, and the femoral neck bone in the hip. Now, there are many other factors that influence how healthy our bones are and how high risk factors is somebody. So the older we get, the higher the risk of developing weaker bones. If we have low levels of vitamin D, and in this part of the world, you know, we don't get exposed to sun in the winter, so we have higher incidence of low vitamin D. People that are inactive, immobile, or that has less physical ability to exercise. For women, being menopausal or postmenopausal drops our estrogen levels, and the estrogen levels are very protective for bone health. Malnutrition and weight loss, and we know that patients that have advanced Parkinson's disease can develop malnutrition because they have difficulty swallowing, chewing, digesting their food, etc. Commonly used medications for many medical conditions contribute to osteoporosis, such as steroids. And finally, patients that smoke have higher risk for developing osteoporosis. And why do we care so much about osteoporosis? Is because osteoporosis increases the risk for fractures, both when somebody falls, but also spontaneous fractures. So, what can we do? What do we advise our patients? Well, number one, check vitamin D levels, vitamin D supplementation if it's required. Avoid malnutrition, maintain weight. Exercise. Another benefit of exercise is to keep your bone healthy. So do as much as you can. If you cannot walk and you're in a wheelchair, do sitting exercises. If you can ambulate, do as much as you physically can. Important to maintain your weight and your muscle mass, as again, vitamin D supplementation. And then there are many specific treatments for osteoporosis that primary care physicians and endocrinologists use. So this is the end of my presentation. I really wanted to leave you with 2 main messages. Number one, that skin conditions are very common in Parkinson's, or more common, I should say, in Parkinson's disease, and that every single person that has Parkinson's needs a yearly dermatological exam. And number two, that we need to take care of our bones. Patients that suffer from Parkinson's are at increased risk for falls, and that put them at higher risk for fractures if they have osteoporosis. Thank you.
I'm Dr. Workman, and I practice out of the Torrington office, and I'm going to talk about mood, memory, and psychosis in Parkinson's today. I don't have nothing more slides beyond this. It's sort of be like MTV and plug. So mood, memory, and psychosis are big categories. They are some of those non-motor symptoms that you can have in Parkinson's, and non-motor symptoms are rampant. Say 98.6% of people with Parkinson's will have some sort of non-motor symptom. Almost everybody, and in a lot of cases, non-motor symptoms can sometimes be even more disabling than the motor symptoms. And so, I'll briefly talk about some of the different classes of mood, memory, and psychotics that symptoms can have. When it comes to mood, one of the most common mood symptoms that can happen in Parkinson's is depression. One of the most common symptoms is depression. They estimate around 50% of people with Parkinson's disease will develop depression at some point during the disease. There are numerous reasons to have depression associated with Parkinson's. Some people think about just situationally having grief about the diagnosis, and yet we distinguish between the kind of mood symptoms that can happen shortly after diagnosis from grief, because true depression should be more long-lasting. There's a chemical basis for depression in Parkinson's disease. We know that Parkinson's disease affects dopamine, certainly. That's usually the first one that jumps to our mind in terms of the neurotransmitters, but it also affects other these neurotransmitters in the brain, such as norepinephrine, serotonin, and those are all important chemicals for regulating mood in people with or without Parkinson's. Symptoms you can have under the umbrella of depression include low mood, loss of interest or pleasure, particularly in things that you used to find pleasurable, changes in sleep, so that kind of dovetails with the talk we had about sleep before, that sleep can be affected by depression, particularly when it's uncontrolled, changes in appetite, changes in concentration or attention, fatigue, slow movements or restlessness and fidgetiness, feelings of worthlessness or guilt, and suicidal thoughts. Anxiety is also a mood symptom that can develop Parkinson's disease. They estimate that it can happen up to 40% of people with Parkinson's, although I think that quite possibly is an underestimate. I think it for some people can be more common than depression. There are a lot of different ways that anxiety can present. Generalized anxiety disorder is what you call it when you have anxiety about a lot of non-specific things, not one specific thing that you're worried about, and can affect anxiety sort of constantly throughout the day. People can have also problems with anxiety attacks, sometimes called panic attacks. When it happens frequently enough, it's considered something called panic disorder. You can have social anxiety, so anxiety about being around other people. Obsessive compulsive disorder is considered an anxiety disorder. And it's, I think, a lot more complex of a disease than is portrayed on TV or movies. But the hallmarks of obsessive compulsive disorder are intrusive thoughts that come about against your will and then actually torment you. Sort of compulsions to do certain behaviors or rituals sometimes. These can be motor rituals where you feel the need to do a certain movement repetitively, particularly repetitively in order to get it right, and you sort of can't move on from it until you've performed the activity correctly. Also compulsions to count things around you, so it can present in a lot of different ways. after having done one of those rituals, gives you to do things and can be particularly disabling. We consider it distinct from the lack of drive that you can get from depression, although and anxiety, but they can frequently co-occur. Apathy can particularly affect social relationships, and it can even trickle down to problems with adherence to treatments in Parkinson's disease. So if you have sort of lack of drive and motivation, it's hard for you to keep up with your medications, especially when you have a really complex schedule, hard for you to keep up with the proper diet and sleep regimen, exercise and things like that. So it can be a kind of a vicious circle. In terms of treatments for the mood symptoms you can have in Parkinson's, there are medications you can use, antidepressants, so-called, can be used for depression or also for anxiety. That's a common point of discussion about why would I take a depression medicine for anxiety? Well, the same medicine is used for both. The most common of the antidepressants act on the serotonin system, although some of them have other chemicals that they work on as well. And having low serotonin levels can lead to the depressive symptoms. So by increasing the amount of serotonin available, it helps with the depressive symptoms as well as anxiety. Benzodiazepines are another class of medications used for anxiety. And the way they work is by increasing binding of the GABA inhibitory neurotransmitter to the receptors to help suppress anxious feelings. Psychotherapy, either with a psychiatrist or a psychologist or even a behavioral social worker, can be a helpful adjunct to help with symptoms of depression, anxiety, and other mood symptoms. The way that it can help is by changing negative thinking patterns and behaviors, and also developing coping mechanisms for some of the challenges that can come out of Parkinson's disease. Another helpful way of treating mood symptoms is to review some of the medications that patients are taking. That includes medicines for Parkinson's and medicines that are not for Parkinson's, because they can have side effects affecting mood. And if you sort of assess the necessity of some of these medications, you can actually help with some of the mood symptoms. Also, just in general, healthy living. So keeping proper sleep, proper diet can be helpful for mood and mood symptoms and anxiety and depression. And being part of a support group can also be helpful for moving forward with these symptoms and developing coping strategies. There are more intense therapies that have been developed as well. Electroconvulsive therapy, or ECT, is a powerful treatment that's used for depression that's failed other means. What electroconvulsive therapy truly means is it's intentionally inducing a seizure through applying electricity to the brain. It's not as spectacular as it sounds, because they use brief course of anesthesia and paralytics so that there's not convulsions happening. But the idea is that they are resetting the neurotransmitters through starting a brief seizure, and it can work when some of the medications have it. Transcranial magnetic stimulation is another treatment that is, I think, less invasive than electroconvulsive therapy, where a wand is placed over the skull and alternating currents of magnetic fields can do something similar, but is kind of less potent for the depression symptoms. It can also be used for anxiety and OCD as well. And then more recently, there's been more research into the use of ketamine in the treatment of depression. And ketamine is particularly attractive because it's expected to have longer lasting effects, because one of the ways that it works is by triggering production of glutamate, which is another neurotransmitter. But by doing that, the thought is that it can actually lead to developing new neural connections for more long-lasting benefit as opposed to just taking a medication to keep the neurotransmitters regulated. So that's currently in trials. For memory symptoms, it's estimated that 50% of people with Parkinson's will have some memory symptoms that would be counted as sort of mild cognitive impairment. Fewer than that, but still substantial quantity, about 40% of patients will go on to develop what's considered dementia. But that's usually not expected to happen until 10 or 15 years of disease. Some of the cognitive symptoms that can come about with Parkinson's include slow thinking, difficulty with memory and retrieval, attention changes, problems with executive functioning and complex planning, and also difficulty with language. Some of the things you can think about to try to help with some of the cognitive symptoms include looking for other causes of things that keep contributing. So sometimes it's as simple as a vitamin deficiency could be causing cognitive symptoms independently of Parkinson's. Sometimes a undiagnosed other medical problem like a metabolic disorder can be also factoring into the thinking. So for example, undiagnosed hypothyroidism can sometimes cause cognitive problems. So these are things that should be screened for. And kind of going back to talking about sometimes untreated mood symptoms can be behind some of the cognitive problems. So making sure to screen for those. Neuropsychological testing is something that we'll frequently send people for with Parkinson's disease. And what that is a very detailed set of cognitive tests, is diagnostic, in order to test various aspects of thinking and memory and see what things are working well and what things are not working well. And you get a very detailed report of somebody's thinking and things that are working and things that aren't. And sometimes you can learn new things and things that you hadn't thought about. So this is a circumstance where sometimes the results will indicate an undiagnosed case of depression, something like that may change the way you think about someone's thinking. Or sometimes the results will point towards sort of a non-Parkinson's cause of a memory problem. So sometimes the results will say this is actually more suggestive of Alzheimer's. It's a combination of both. So it can be a helpful additional tool to look for other causes of memory changes. There are medications that can be used to help with thinking and memory in patients who have dementia. So one class is called acetylcholinesterase inhibitors. And the way that those work is by increasing the amount of chemical called acetylcholine available to help with thinking and memory. What I also like to play up is speech therapy. So a speech therapist is trained in doing cognitive therapy as well. And they have exercises they can do to help with attention and concentration, help with orientation, problems with language. And then they also can offer strategies for how to accommodate for the symptoms such as visual aids, simplifying the language that you use, using certain gestures or cues to help make it easier to function, and then using technology. So sometimes they'll suggest using a smart speaker like the Alexa, things like that, to help make your life easier to accommodate for some cognitive problems. Using pill timers, using your cell phone to give you reminders and keep time of medications and things. So they have a lot of useful suggestions for how to accommodate for some of the cognitive symptoms. With regards to psychosis, psychosis is classically thought to be more of a side effect that you get from Parkinson's medication, but it doesn't actually always have to be the case. You can have hallucinations even before starting medication. So, but we know that the medications can actually increase the risk for having those symptoms. The dopamine that we use as a treatment in Parkinson's goes through a pathway called the nigrostriatal pathway that is involved in helping you to make movements. But there are other pathways that use dopamine too. So there's one called the mesolimbic tract that is one that's involved in diseases such as schizophrenia and causing hallucinations. So by giving people dopamine to supplement their nigrostriatal tract, unfortunately, some of the dopamine can affect the mesolimbic tract and cause hallucinations. The hallucinations that are seen in Parkinson's are typically well-formed hallucinations of people or animals, as opposed to something nebulous. They're not always scary, but they can be. They're frequently occurring at specific times during the day, like in the middle of the night. There are even mild forms of hallucinations where just a flicker of something out of the corner of your eye, that can sometimes be a presentation of a mild hallucination. We draw a distinction between that and illusions, and illusions are not seeing something that truly isn't there, but it's having basically your vision making a mistake and seeing something that actually is there, but seeing it incorrectly, and thinking that it's something that actually isn't. I also just wanted to mention vivid dreams and the REM behavioral disorder. We do consider that different from hallucinations, because the hallucinations should be happening while you're awake, although it can be difficult to tease them apart sometimes too, because we know that the hallucinations frequently occur in the middle of the night. And sometimes there can be some blurring of the border between your wakefulness and your sleep. It can make it difficult to tell the difference between a true hallucination and just a dream carrying through. Now, delusions are a belief that something is occurring that actually isn't occurring in reality. There are common delusions, including delusions that your spouse is being unfaithful, or that someone is trying to steal from you or take advantage of you. There's a classic one called Capgras delusion, where you think that someone or multiple people that you know have actually been replaced and are being impersonated by some imposter. And I mentioned that these can be exacerbated by the dopamine medicines, but not just levodopa, but other ones as well. Dopamine agonists, amantadine is a medicine that's used that frequently has a risk for hallucinations. Some of these anticholinergic medications that are older medicines used for tremor, and even some sleep aids can cause hallucinations. You can also have increased risk of hallucinations when you have delirium or dementia. Now, when to treat hallucinations historically has been controversial. For a long time, there was an idea of so-called benign hallucinations, where someone was having mild hallucinations that weren't really interfering with their functioning. The thought was maybe it's not worth treating them in the first place. And it seems that the pendulum is swinging on that we're being more proactive with treating hallucinations. Think about treatment of hallucinations, psychotic symptoms. The class of medications are called antipsychotics. And there are multiple different kinds of antipsychotics. The older ones tend to be less preferable in Parkinson's. We really have a strong preference for the newer versions of them that are less likely to block dopamine in ways that are going to exacerbate Parkinson's symptoms. They call them more third generation or atypical antipsychotics, and the ones that are most preferred by movement disorder specialists are called quetiapine and clozapine. But also some of the acetylcholinesterase inhibitors that are used for dementia can actually help with hallucinations as well. So that's another class that's attractive to use for psychosis. Some of the reasons to be optimistic about the treatment of these conditions: there's a new antipsychotic that was developed. It was approved in 2016, and its real claim to fame is that it actually doesn't work on the dopamine system. It works on the serotonin system, so that's particularly attractive when you're looking for a way to treat these psychotic symptoms without exacerbating Parkinson's symptoms. By not having any binding to dopamine receptors, this medicine called pimavanserin has particular advantage in Parkinson's. So it is a FDA approved treatment of hallucinations and delusions in people with Parkinson's. Other things that I think I like to be optimistic about are that ability to use acetylcholinesterase inhibitors for memory and psychosis sort of concurrently. And then I also like the use of non-medication interventions such as speech therapy and psychotherapy because they don't have the same risk of side effects. The other thing that I'm excited about is ketamine. I think it has real promise, but will remain to be seen as the trials conclude.
What we're going to do now is take your questions on these themes, and Dr. DiMarcando will
Yes, because we have so much to share. We were thinking we were going to do a working break. So we have 10 minutes to take a break. But during that time, our 3 excellent speakers from earlier today is happy to take questions. But feel free to get up, walk around. We're breaking for 10 minutes. Michelle, Marissa, and did anyone have any questions about sleep, mood, memory, and psychosis, and skin and bones?
I have a question with regard to sleep and sleep disorder. What are your thoughts on a combination of melatonin and clonopin, clonazepam? In particular, I have wild disease, so I have REM sleep disorder, time in my sleep. I knew I was waking up my kids at 3 a.m., getting them back in the middle of the night meetings, all the times they woke me up. But I'm a sleep talker, so I still wake up 3, 4 a.m. and my average sleep, no matter what I do, I can't seem to break that 6 hour a night type of situation. So I'm a sleep tracker on my Strive PD, and I'm noticing that my REM, I'm under the percentages where I want to be. So, I know there's adjustments and it's really your recommendation.
Yeah, that's a great question. So she's asking, can you take melatonin and take clonazepam at the same time? You've got goals for how much REM sleep that you want to be in. I think the tricky part is that, so we've got this great wearable technology. I've got my Aura ring, I track my own, but part of what we're trying to do is actually suppress the REM sleep. So it's right. So when you're treating that REM behavior disorder, when you're talking and you're sleeping with the kids, like you said, I've got young children, you're going to see those REM numbers come down. What you really want to do if you're doing like a sleep tracker is follow your own trends. So don't gauge yourself against the general public. They say that even kind of within the population itself, but I find especially when it comes to Parkinson's, I deal a lot with young onset women in particular. You're going to notice real fluctuations, psycho-related, non-psycho-related. There's a lot of changes that we see hormonally. Try and follow your own trends for REM. It's okay to use both. So the answer to your question is it's okay. If you're noticing that you're having a lot more difficulty around that 3, 4 a.m. time, what I would try and do is try and do the bi-layer melatonin if you're not already doing it. Most times people are not. Are you doing the bi-layer? Yeah, I would try the bi-layer first because you're going to get that initial release, and then hopefully it's going to carry you through. There's a lot less side effects, right? With that bi-layer, we don't want to give prescription medications that are sedating to people at any age, regardless if we can help it. If the bi-layer doesn't help, I would start with 5 and then go to 10. And I typically will push to 15. Again, you want to speak to your clinician about it, but then it is safe to use the clonazepam on top of it. If you're finding a clonazepam hangover, you can always talk to your clinician about slightly shorter acting versions.
So I have a question for you, Doctor. I'm sorry.
Oh, that's okay.
Your name?
D'Agostine.
That's the one. So, fortunately, we are going away next week, 2 weeks. But I've been going with my son who's 41. He's moved out of the house. So I've been sleeping in his room. My wife's been sleeping in our bedroom. I'm concerned that if we go to the hotel, we're going to be in the same room. Would you recommend, for instance, at the hotel we're staying at, because we've got person used to them going out further, that we get connecting rooms as opposed to being in the same room, because I'm not used to sleeping in the same room?
So that's a great question. It's asking about, when you have it set up at home and then you're traveling and how it differs. I do find with people that sleep disorders tend to kind of pick up when you're traveling. So when you change locations, I think it depends on why you switch rooms. If it's, sort of being in the same bed, you were like hurting her or keeping her awake, is that happening? No. I mean, I think it's a conversation you have together. If you can be in the same room and you're not yelling and disrupting your sleep and you're not gonna hurt yourself, I think it's fine to stay in the same room. I mean, there are some people that will do, connecting rooms, but I would anticipate a little bit of a kick up in your symptoms, your sleep symptoms, and your, we call them arousals in the middle of the night when you travel. Because as you go through those cycles, every time you complete like the fourth stage, you're gonna go back to that stage 1 light sleep. And your body is going to recognize that you're not in your home or in your son's room, and you're going to wake up. It's a survival sort of mechanism. It might be beneficial to stay in the same room if you can tolerate it, just because that way at least you have someone from home to kind of be with you, Definitely separate beds.
Yes, we have time for one more question.
Yes, does it tend to get worse? And also, is it related to stress or any other environmental thing that might be going on?
Yeah, so the REM behavior sort of question is it related to stress or environmental concerns? I tend to find that it waxes and wanes, right? So it doesn't sort of progressively get worse and worse and worse over time. You're going to see it sort of ebb and flow. Stress does tend to make it worse. If you've got a lot on your brain, if you're dealing with a lot of stress, and your brain's trying to kind of work those things out in those deeper stages, I do tend to find that those are time periods where people might have more operatively, things like that when your body's sort of repairing. But it's not stagnant, it's not going to stay that way. So if it's happening, that's why you need to have that kind of ongoing question with your clinician. Just because you're on a medication for it doesn't mean you have to be on it forever. Certainly if you've hurt yourself, it's a separate consideration. To answer your question.
And we will be hanging around over lunch and after the whole presentation as well for more questions. But we'll proceed with the next quarter of the presentation.
This one? That's okay. Hi, everybody. Good morning. So, good afternoon. Good morning. Hi, my name is James Duffy, and I am a proud member of the Chase Family Movement Disorder Center, where I work as a integrative neuropsychiatrist. So that sounds like a mouthful. So hopefully it'll make sense by the time we've had our little conversation today. And I have two goals for today's conversation. My first goal is to show you two very simple but incredibly powerful breathing techniques. That's my first goal. And my second goal is to motivate you, scare the hell out of you, convince you, motivate you to actually practice these. All right? So I have these hats. I'm an integrative physician. I'm trained in integrative medicine and classical Chinese medicine. I'm also a neuropsychiatrist. Spent most of my career as a clinical neuroscientist. So how do we bring these hats together today? Well, first hat, Western doctrine. I need to convince you to learn how to breathe, to do breath training, because the research shows that if you have Parkinson's disease, you don't have very efficient breathing. Okay, and that's because you have poor muscle strength, poor respiratory excursions, many reasons why you don't breathe very well. So, plain and simple, you need to see some about breath training or learn how to optimize quality of your breathing. And another reason, which is kind of interesting, is there was a paper last year published in Nature magazine, which is really the #1 scientific journal, we could argue, which was reported that these researchers were able to diagnose people who were going to develop Parkinson's disease, at least have symptoms of Parkinson's disease, 2 or 3 years later, simply by observing how they breathe. And artificial intelligence would actually very accurately predict who would end up with Parkinson's disease and other diseases. So as a Western medicine doctor, have a diagnostic test based on your breathing, and good idea that convinces you there's something to do with breathing that affects or results in Parkinson's. So might as well learn how to breathe certain ways, right? Of course, one day, not too long from now, not even our children will be sitting in a room like that, and there'll be cameras everywhere, and they'll be monitoring how we walk, how we breathe, how we speak, and then we'll get a little message on our smartphone saying, "Oh, congratulations! Based on your breathing pattern today, we've lowered your health insurance by 2%." And that's not a strange thing. Of course, in China, that's already happening. People are being monitored on the streets to see if they're having genuine smiles or fake smiles when the great leader walks past. So this is, there's one justification to talk about breathing, but that's all I'm going to talk about from a Western medicine point of view. I like to say that in Western medicine, I live in a world of straight lines. There's a cause and there's effect. And only one cause and one effect, because if you have more than two causes and two effects, then it gets really messy when it comes to doing a research study. You have very simple straight line medicine, right? Newtonian medicine. Now, a number of years ago, I was working as a neuropsychiatrist at MD Anderson Cancer Center and working with people with very serious disease. And we had a wonderful team of acupuncturists, and they would come and see patients, many of whom we couldn't help. And this was things like sleep and fatigue, constipation, and they would do incredible things. And I thought, gee, this is really interesting. I need to speak to these folks. And I learned more and more about this way of doing medicine. And I said, gee, I need to study this. So I went and became an acupuncturist. And the hardest thing about becoming an acupuncturist was that I stopped living in just the straight lines, but living in a world of curved lines and relationships. Quantum physics, right? That everything is relational. Nothing lives by itself. Martin Buber said to be human is to be relational, right? So you've heard a bunch of things this morning that, gee, that's kind of strange. You've got one doctor's talking about sleep, and one doctor's talking about the skin, and one doctor's talking about bones, and one doctor's talking about mood and anxiety, and Charlotte will be talking about the microbiome this afternoon, the large intestine, at least that's part of the microbiome. Boy, so how do we put all of these things together, right? I mean, skin, bones, movement, nervous system. Well, in Chinese medicine, it actually makes obvious sense, right? Chinese medicine says that everything is relational, that we're all manifesting in the world in relationship to each other, and we come into this world with our own patterns. You can call that qi, you can call it genetics, whatever, but we come into this world with patterns, and we create these resonant ripples with each other. So in Chinese medicine, the first thing we do is we say, okay, what is Parkinson's disease? Well, Parkinson's disease, really, if you think about it, is a disorder of our ability to effectively move through time and space, right? We have difficulty getting going into the space, we have difficulty maintaining the movement, we have difficulty timing it right. It's a disorder of time and space. And so in Chinese medicine, Parkinson's disease essentially involves what's called the lung large intestine channel. So there's these channels. And actually, what are the lung and the large intestine? What do they govern? They govern the lungs, they govern the skin, right? Isn't that amazing? And so, absolutely would be surprising from Chinese medicine if people didn't have skin problems, right? And what we've learned in the last few years is that Parkinson's disease looks like it starts in the large intestine, the lung, large intestine channel. This is all my way of trying to build up an argument to suggest that it's really important to focus on our lungs and our large intestine as soon and as early as possible in order not just to slow down the disease, perhaps even reverse it or change it, who knows, okay? So a number of years ago, some very smart neuroscientists were meeting with the Dalai Lama in India, and they were talking to him about cognitive behavioral therapy, these new findings that we have about how we think and how we can use therapy to change people's stories in their heads, right? We all have these stories. And halfway during the morning, His Holiness Dalai Lama stopped and said to this researcher, how did the Western world allow their minds to get in such a mess, right? How did they get in such a mess? Because of course in his tradition, working with your mind is just central to being healthy. And you're constantly checking in, am I thinking right, am my motivations right? Well, I would say that we can use the same argument when it comes to breathing. How did we allow our breathing to become such a mess? And before I forget, I want to show you this book. So if you want to follow up, this book is called Breathe. It's by James Nestor, Nestor. It's about 5 years old now. This book has really changed the conversation in this country, at least, about taking breathing seriously. And yes, we have terrible breathing hygiene. Our breathing is a mess, right? And James Nestor goes into some of the reasons for that. For example, our diet. Our diet has completely changed our facial structure, changed our pharynx. It's changed how we actually breathe. Americans, most of us breathe through our mouths. Yeah, we're going to do an exercise. I'm going to go through this with you, why we should not be breathing through our mouths. Okay, so I'm going to go through the science of it as well. The amazing thing is that now we actually have the science that's smart enough to actually explain the age-old wisdom of these healing traditions. That these folks knew what they've been doing it for thousands of years. I mean, if it was all wrong, they wouldn't. I mean, human beings just don't continue to do things for thousands of years if it's not helpful in some way. So we now have the science. We're going to talk about that. I'm going to go through 2 exercises, simple exercises. These are exercises that I do myself all day long. What we need to be able to do is move towards creating healthy habits of breathing. The same way we have healthy habits of eating, healthy habits of movement, healthy habits of sleeping. Michelle talked about you. Men, sleep hygiene, right? These are healthy habits. And actually, you can look at breathing from a physical perspective, a psychological perspective, and a spiritual perspective, right? The Buddha said, and this really caught my attention, the Buddha said, the poor guy was out there in India wandering around trying to figure out how he could escape suffering, and nothing was working very well. He almost died of starvation, and one day he said, I'm not going any further, no more gurus, I'm just going to sit under this tree, and I'm just going to figure it out. I'm not leaving until I figure it out. And something suddenly happened. And the first thing he said was to his disciples, what's for lunch? Right? And the second thing he did was he wrote down the Anapanasati Sutra, which is a sutra teaching on breathing. And the Buddha said it wasn't until that moment that I discovered the power of breath that I was truly able to escape the bondage of this experience of being a human being. So breathing is really the gateway to physical, psychological, and spiritual well-being. And if you had said that to me 30 years ago, I would have laughed you out of the room and said, especially because you wouldn't have any science. Now I have science to support what I'm saying. So what I want to do, I don't want to overburden us with facts. I want to go through 2 breathing exercises that we can do together, very, very simple. And the goal of these is that you will begin to reshape your breathing hygiene, right? And like I said, most of us have terrible breathing hygiene, and it's killing us. And we're not even aware of it. How much time have you spent today observing the fact that you have had about 2,000 to 3,000 breaths before you heard me speaking today? You don't, right? 20,000 breaths a day, you do the numbers. It's a lot of breathing. And what happens as we go through life, our pattern of breathing changes in response to our experience of relationships. And so what you see, for example, when you see someone who's been through a traumatic experience, what happens when you suddenly have a traumatic experience? Hold your breath, right? Many people that I work with, they're still holding their breath after that traumatic experience in childhood. It changed the pattern of their breathing. They got stuck. And that's not a great way to breathe. You're not moving much, all right? So let's go through 2 exercises, because I really want to make this the focus of what we experience today. And I urge you to think about trying them out. And as I explain them to you, I'm going to explain a little bit of the science that goes with each part of this, okay? So I'm going to take a seat. You move my, I guess I can just stand, that's right. So, all right, so breathing, something that's natural, but actually it's the only, what you might call vital function that we have as human beings that we can very easily, consciously control. I mean, think about your bowels, for example. Think about your bowels. It's very hard to control your bowels, isn't it? It's very hard to control your heart rate, but you can. It takes a lot of exercise, right? Like we could talk about what's happening right now in training of Navy SEALs and Special Forces. They're learning these skills. In fact, if you want to make a lot of money on the stock market, you learn how to become an accurate interoceptor, how you learn to actually perceive your body. You know, I trained as a neuropsychiatrist. Everything is from here up. Okay, James Joyce in his book Ulysses, one of the main characters in that book is called James Duffy. And there's a quotation in there, James Duffy lived a short distance from his body. Okay, that's most of us, right? We live here. And yet actually what we know now is actually more information goes from here to here than from here to here. Our brain's job is a GPS, right? That's what it's doing, it's just a GPS. In Hindu philosophy, you know, the chariot, the breath is the stallion and the mind is the charioteer. And in Western medicine, we've lost the vital point, which is it's about, what about vitality? What about energy? What about prana? Tibetans talk about lung, right? We have all of this. I have 5 minutes? Oh my goodness, okay. So we're going to do the breathing. All right, because that's what I really wanted to focus on. So 5 minutes. Okay, first breathing practice. This is called the 9 breaths. The 9 breaths. This is an ancient tradition that's used in virtually every Eastern religious tradition as a foundation practice. So what is this? This is called alternate nostril breathing. Okay, and the belief is that there's a left channel, there's a right channel, there's a middle channel. Aversion, attachment, and ignorance. And that actually, we know now from science, is a 90-minute cycle between each nostril. Look, if you observe, difference, right? Our nostrils alternate in their dominance. Which one's more open and more closed? When you actually breathe through your left nostril, you activate the right side of your brain. You breathe through the right side, you activate the left. Activation of the left is associated with a positive mood. Activation of the right is more associated with hypervigilance, anxiety. And when you breathe through both nostrils, you are, what we might say, have relaxed attention, calm but attentive. So this is the practice. Start, breathe through the right, and then let it out through the left. Now, you should have a tissue with you when you do this. Because what you want to do actually is you breathe in, and then you let it push it out the other side, right side, and because that snot that comes out, that's not actually in Chinese medicine, it's phlegm, which is stuck heat, stuck energy. So you do 3 on the side, and then you change sides, right? And then you do both breaths, and then up through the middle. You don't have to, in some traditions, you'll see all kinds of fancy movements. No, you can just, and then out there. This is the 9 breaths. I've been doing this for quite a few years now. It stabilizes you, it gets you back on an even keel. That's the first step, that's the first breathing, the 9 breaths. You can go online, there's some wonderful videos from teachers, the 9 breaths. Now the next one. Okay.
Wait, are we gonna try that? Did everybody try it?
I've got about 2 minutes left. Okay, so the next one is what I call the foundation breath. Now, of course, in India and other traditions, they have there are hundreds of different breathing practices. Pranayama, stretching the breath. You know, in China, they believe that each of us is given a certain number of breaths when we're born, and when we've used them up, we die. So, Breathing like that is not a good idea. Okay? So this is the foundation breath. As I mentioned earlier, as a consequence of our relationships, our experiences, our lifestyles, we develop breathing patterns. And what I want to show you now is how to develop a foundational, healthy breathing pattern. So first of all, what I want you to do is just sit. And I want you just to take some breaths. Okay, so what I want you to do now is, can you tell me what was easier for you, breathing in or letting it go? In for you, out, in, easy in the beginning, more difficult towards. We all have our own breathing practice that kind of breaks ground into about 5 different patterns, right? Were you breathing through your nose or your mouth? Nose. Well, good. All right, so you need to sit comfortably. We sit straight, a straight spine. You can't breathe if you're like a pretzel. I mean, just think about the dynamics of this, right? You have 480 million little air sacs in your lungs, all right? So here's the next one. We sit straight, okay? We breathe in through our nose. Why do we breathe through our nose? Because in our paranasal sinuses and at the back of our noses, there's this tissue. It's like the same tissue you have in your genitals, particularly the gentlemen, all right? And when you breathe through your nose, it actually swells that tissue and it releases something called nitric oxide. And nitric oxide is literally like Viagra for your brain. And this is the recent study that people who take Viagra, it looks like there's a good possibility they have a much reduced chance of getting Alzheimer's. We don't know about Parkinson. So there's nitric oxide is a very important, I have one minute, very important transmitter. And we know that nitric oxide will change dopamine efficacy, I guess you could say, affects inflammation, antioxidation, all those things. Okay, that's why we breathe through our nose. So sit straight, breathe through your nose. As you're breathing in, you do staircase breathing. So you take a series of breaths, because imagine that your lungs, 480 million little balloons in your chest, need to be maximally inflated, just like a balloon, in order for them to collapse down efficiently. If you just blow the balloon, it doesn't really, just not very efficient, right? So this is what staircase breathing looks like. You can try that. Take a few in-breaths, whatever you're comfortable with. Could be 2 in-breaths, could be 3, could be 6 little ones. But just try that staircase breathing, maximally inflate, and then just let it go like a balloon.
Why do you call it staircase?
Because it's a number of steps. You're building it up.
It looked very smooth what you were doing.
Well, it's not always smooth. I mean, I've been working at it. I'm happy to hear it looks smooth. But actually it's going, you know, if you're out of shape, you're going down the staircase, it's kind of hard. So, but you'll notice where it gets stuck, right? So you do the staircase breath, and you notice that my out breath was longer than my in breath, right? So what the science has recently showed from Stanford is that if you can have your out breath at least 7 seconds, that's how long it takes for your brain to believe your body that you're actually safe. And if you can't do 7 at first, that's fine. This is relaxed. Your body knows what to do. The way you breathe is a reflection and will drive your stress response, okay? When you breathe in, you're actually going into fight or flight. You're approaching something, right? And when you let it go, you're releasing it. Your breathing is an indicator of the balance within that old survival brain, right? And actually, when you breathe, it's reflected on what's called heart rate variability, that your heart rate is never regular. The moment your next heartbeat is exactly the same as the one before, is the last heartbeat before you die. Our heart is a space where there is continual movement of energies coming in from all parts of our experience. And in Chinese medicine, the image of a medicine is a musical note within the heart. So when we find balance, when all of those things are unbalanced within our heart rate variability is maximum, and heart rate variability is the best predictor probably of life expectancy overall states of well-being. So there are things like the Aura Ring, other things that are measuring heart rate variability. So breathing really is the royal road to balance and harmony and creating music in your life. So 30 seconds. Sit straight, breathe in through your nose, let it out. And finally, out breath. You make the sound of a humming in Ayurveda, Indian medicine, bumblebee breath. Why do you do that? Because when you hum, you increase the production of nitric oxide by 1,600%. You're getting a massive dose of nitric oxide. So this is my final thing. Sit, straight spine, breathe in. And God lives in the space between the out breath and the in breath. Viktor Frankl said, in that space between stimulus and response lies your choice. As you do this practice, you will begin to relish that moment at the end of the breath where you don't have to go forwards or backwards, breathe in or out, but simply rest in the presence of that moment that's available to you free of charge, without side effects. We just have to be aware of what we're doing and create new habits. So I've gone over time, I'm sorry about that. I hope I've motivated you. Just start with the book, it's really fun.
I feel I have to stop right now. Everybody wants to go to lunch, perhaps. Daphne was supposed to speak after me, then sorry about this change. I feel like no words should be said right now. But thank you so much for everybody who was talking before me.
No apologies necessary.
Elena Borton is my name. I'm working with Chase Family Movement Disorder since 2019. A great team here, and I have the privileges and I'm so proud to be part of this team. I'm talking today about levodopa, past, present, and the future. We have to talk right now about some medications which can be used to treat some symptoms of Parkinson's disease. Levodopa is known to be as the mainstay of treatment for Parkinson's disease for more than 50 years. During this time, researchers have tried to optimize levodopa for patients to minimize side effects, enhance central nervous system bioavailability, and achieve stable therapeutic plasma level of levodopa. Why am I talking about levodopa today? Because many of you perhaps you heard about, and unfortunately some of you have to use this medication for treatment of Parkinson's. I guess I'm not able to use the microphone. I'm not going to scream. I can try on my best. Did I do something wrong? Okay. But Parkinson's disease.
Parkinson's disease was first described in early 18th century by Dr. James Parkinson. And he described those patients who had tremor and stiffness and difficulties in walking as shaky palsy. Later on, there were many patients speaking the same pattern, and actually later on was described the disease wearing his name of Parkinson's disease. What is the link between levodopa and Parkinson's disease? Levodopa is first of all dopamine. Perhaps you hear my colleagues discussing about dopamine.
And dopamine is very important in the pathophysiology of Parkinson's disease. Actually, many times was, for a long time, was feeling that dopamine is the one which is the trigger and the cause of Parkinson's disease. And actually, it has been noticed that dopamine has been in low levels in the brain in patients with Parkinson's disease. Then we have dopamine, we have to create dopamine in the brain of patients with Parkinson's disease. And many medications has been invented, or the way in which levodopa or dopamine can be increased in the brain of the patients. The history of levodopa begins with isolation in the beginning of 19th century from a seedling of a type of being called Vicia faba. Then this was the beginning of 19th century. 50 years later, levodopa was used in treatment of motor symptoms of patients with Parkinson's disease, and this was considered as a miraculous drug to treat different symptoms of Parkinson's disease. During that period of time was found an enzyme which was felt to help the levodopa to be transformed in dopamine. And during the same period of time, it was demonstrated that some areas in the brain called basal ganglia are very important in the in our function of the brain. And also has been demonstrated that dopamine could be found in the basal ganglia. It was very important when a neuropharmacologist in Sweden demonstrated that dopamine it has been a neurotransmitter. He demonstrated that dopamine is a neurotransmitter, and actually this a neuropharmacologist by the name of Arvin Carson received the Nobel Prize for discovery and demonstrating that dopamine is an important neurotransmitter in the brain. What is a neurotransmitter? Is making the cells in the brain to speak one with each other. It's not just the dopamine, which is a neurotransmitter. There has been many neurotransmitters in the brains, but today we discuss mainly about dopamine. And we discuss about how can we increase the level of dopamine in patients who have Parkinson's disease. Then before discussing about how to increase the level of dopamine, I would like to you to imagine Parkinson's disease as an iceberg. It's not my idea. This idea came somehow in 2006 and was described as Parkinson's disease having the tip of the iceberg representing motor symptoms of Parkinson's disease. What are the motor symptoms? Motor symptoms are tremor, slowness of movements, stiffness, and postural difficulties and loss of balance. But during the years, we have learned that Parkinson's disease is not just motor disturbances. Parkinson's disease also has a lot of non-motor symptoms. And what we are noticing below the surface of the oceans are all of these non-motor symptoms, and my colleagues already discussed about sleep disturbances, including REM sleep behavioral disorder, anxiety, depression, skin problems, bowel and bladder changes, changes in temperature regulation, also difficulties with pain attention, confusion, loss of taste and smell. Many of you perhaps experienced that. And also cognition decline and dementia, which is being described in patients who had Parkinson's disease. In patients with Parkinson's disease, we are using non-pharmacological treatment and pharmacological treatment. Of course, many patients start to be challenged by using non-pharmacological treatment, and many of our patients do not want to start medication right away, and we are respecting their wishes. But sometimes we need to realize and discuss with our patients when there is a need to start something to improve their symptoms. And when I'm saying their symptoms, I'm talking here about motor symptoms, especially stiffness, slowness, sometimes tremor. Why? Because this can affect them and impair their quality of life. We decided to start pharmacological treatment when symptoms start to affect the quality of life, including impaired job performance, impaired recreational activities, and also social withdrawal. How many patients of us are staying in the house trying to avoid going to see a game of their grandkids because they are afraid? They do not want to start losing balance in the field, or having tremor there, or having difficulties in entering in the car or getting outside of the car. Then many medications to help them improve those motor symptoms have been created. And one of the medications, which I said is gold standard of care in treatment of motor symptoms of Parkinson's disease, is this levodopa. This levodopa was approved by FDA in 1968, and as of date is still being the most used and more efficacious drug to improve motor symptoms. As I said, levodopa is a precursor of dopamine. As I described, dopamine is a neurotransmitter. It is in our nervous system, and it is used to send messages between the cells in our brain. Dopamine plays a role in how we feel pressure. It's a big part of our unique human ability to think and plan. It also helps us to strive, focus, and find things interesting. Dopamine is also playing an important role in the initiation of starting movements in the body, and this is very important because patients with Parkinson's disease who had low dopamine level, they start to have decrease in movement modulation, decrease in initiation of the movements, decrease of starting a movement, starting walking. It's, this freezing of gait, I don't know how many of you heard about, which is described like a patient being stuck on the floor without being capable to initiate walking because of lack of initiation of movements. This is what the dopamine is doing, and this is the way in which we are trying to help these patients to build the dopamine level in the brain by giving different types of medications. Dopamine, levodopa is one of the precursors of dopamine. This is what I was saying already. Levodopa has been used by our ancestors, and we have data about Indian Ayurvedic physicians used the seeds of Mucuna puris as early as 300 BC. Then Mucuna puris contain about 4% to 6% of levodopa. Now, there is a problem. If patients are taking levodopa, there are many obstacles in levodopa to arrive in the brain to be transformed in dopamine. In the stomach, the levodopa part of levodopa is destroyed by the acidity of the stomach, and then should arrive in the small intestine in order to be absorbed. Then people created a way in which levodopa was supposed to be to avoid it to be destroyed in the gut, in the small intestine. And in this way, carbidopa was invented. Carbidopa is a drug that blocks conversion of levodopa to dopamine outside of the central nervous system. and subsequently inhibits unwanted side effect of levodopa or of dopamine in the organs which are outside of our nervous system. Many patients have nausea, vomiting when they are taking levodopa, and this is the reason for which carbidopa was a savior. And those patients in 1961, when levodopa was was used for patients, was a big success in decreasing the side effects of levodopa for patients. Then in this way, then we discuss about carbidopa, how carbidopa is helping the levodopa to win, to go over obstacles in the stomach, in the intestine, and enter in the bloodstream without being destroyed and without having the dopamine to have side effects outside of our brain. Then during the years, as I said, levodopa was created and was approved by FDA in 1968. Then a component, a type of medication, carbidopa levodopa, was approved in 1973. 20 years later, a control release carbidopa levodopa was created and approved. Later on, many other medications containing carbidopa levodopa, trying to maintain the life, to prolong the life of levodopa in our system, were created to the point where in 2015 a specific device was created to deliver carbidopa levodopa directly in the intestine. As Parkinson's disease progresses into the middle stages, the dopamine level of patients with Parkinson's disease started to decline or continue to decline. As a result, many patients start to notice that when their medication starts to wear off before the next dose of medication, they become stiffer, slower, or have more tremor. When they take next dose of medication, it is also taking longer for it to take effect. We refer to this as motor fluctuations, when patients go from feeling on when their medication is working well to off when medication level drop and cause the patients to move more slowly. Why am I discussing about this? Is because the more you are using carbidopa levodopa over the years, more patients are noticing this motor fluctuation. And there are two main ways to address these fluctuations, either by increasing the level of dopamine in the system, in the brain, either by prolonging the life of levodopa. Giving more dopamine in the brain, that means that more side effects, increasing the dose of levodopa, that means that more side effects of levodopa can be noticed, especially nausea, vomiting, other side effects like orthostatic dizziness due to orthostatic hypotension can be noticed. Dyskinesia is an involuntary movement characterized by twisting or turning some specific parts of the body. Patients cannot control this dyskinesia and can be noticed when we are taking too much levodopa, or if we notice when we are taking the same level of levodopa for many years. Then increasing the dopamine level, the dopamine can be done by increasing the dose of carbidopa levodopa, having patients take more levodopa, but as I said, some patients may notice more side effects of levodopa and may notice also having more dyskinesia. Then what can we do for these motor fluctuations? As I said, over the years, from mild to moderate to severe Parkinson's disease, the on-therapeutic window of levodopa has been noticed to decrease, and patient has more off time when motor symptoms of Parkinson's disease are affecting the patient and affecting quality of life. there are different combinations of carbidopa, levodopa, regular immediate release, extended release, or combination of carbidopa, levodopa, immediate release, extended release. Here the diagram which is showing which one of the medication is staying longer in the bloodstream, and because this is the idea of having longer level of levodopa in our system in order to stimulate constantly the dopaminergic neurons and without having fluctuations in the blood level of levodopa. Those are different types of medications which are containing carbidopa, levodopa, and there are different types of tablets, capsules. There are different combinations: carbidopa, levodopa, immediate release, carbidopa, levodopa, immediate release, and extended release. Those capsules. I don't know if I'm allowed to say the name. Then perhaps. Some of you here, if we are using carbidopa, levodopa, heard about Rytary. There are combinations of carbidopa, levodopa with etacapone. This is a medication which is helping the life of levodopa as well by avoiding to break the levodopa in the bowels in our body. There is also a type of rescue inhaler, and if you notice here, it's called Imbrija. This is a medication which is recommended to patients who are taking already carbidopa, levodopa during the day, when they are having severe off time, when they are stiff and slow, and they need to move. They can use this type of inhalers. It's like inhalers which we are using for asthma, for example. We can use this type of inhalers up to 5 times a day. Is it not replacing a usual medication, usual doses of carbidopa, levodopa during the day? Then later on, some of devices has been found and created for patients to receive a continuous carbidopa, levodopa directly in the intestine. Then, as I said, by the time Parkinson is progressing, more motor fluctuations are noticed, and we have to find out medications to decrease those motor fluctuations. There are medications and there are devices. Some of the patients are going, due to severe motor fluctuations, are going to decide to have a surgery. This type of surgery is called deep stimulation, which is recommended to patients who are very well, very well examined to see if there are candidates for this type of different stimulation. But some of the patients cannot have this type of surgery procedure. Then in these situations, we are trying to have them receive a continuous dopaminergic stimulation, which may delay or prevent the development of motor fluctuations and dyskinesia. And this is a device which is used, was approved in 2015 by FDA, is delivering carbidopa, levodopa directly in the small intestine. Is a pump which is containing a gel of carbidopa, levodopa, which is connected with the medication port, which is going through the stomach by a pore which is called stoma. Is bypassing the stomach and is delivering the carbidopa, levodopa directly in the intestine, and is performing a constant absorption of the levodopa, which is very important in the patients who have motor fluctuations. This is a type of carbidopa, levodopa enteral suspension. And has been noticed to be very successful in patients who cannot take oral medications, who are taking medications every 2 hours, we cannot go for deep brain stimulation. Many patients consider that is an invasive procedure, having a hole in the stomach, and they would prefer some other methods of avoiding this type of motor fluctuations. What is the future of levodopa? We have hopes and we have definitely future. The future of levodopa is using a subcutaneous 24 hours infusion of levodopa-based therapy. I'm not going to say the name. It's approved already in UK, countries of Europe and Japan, and we are hoping for this type of medication to be approved in United States soon. Imagine that this is a type of insulin pump which is attached to the skin, and the tube is delivering continuous type of levodopa under the skin, and can be used for 24 hours, and patients notice a significant improvement of on time and significant decline in motor fluctuations. Some other future, and for levodopa, and I didn't write it here, are making a pill which can be taken once a day, a pill of carbidopa levodopa. Of course, though, this is something which is technically very hard to be performed, because we need to place in that pill a higher dose of levodopa. But people are, researchers are trying to find a sustained release floating mini tablet to stay in the small intestine and deliver slowly levodopa during 24 hours. Also, another future for using levodopa without having any kind of intervention like a stoma or wearing a pump is to place levodopa into a transdermal patch. This is the future of using levodopa in the treatment of Parkinson's disease. I guess we have hopes in using different types of treatment, and my message for today is that although the levodopa is the gold standard of care in treatment motor symptoms of Parkinson's disease, researchers and doctors are coming together trying to find what is the best for patients to improve quality of life, and without having invasive procedure or taking medications, every 2 hours, every 3 hours, and indeed, yes, having a good quality of life. Thank you so much.
Doctors, the ones who spoke this morning, and we can't wait to hear the ones who are speaking this afternoon. I want you to know that it's a lunch break now, and it's a time for all of us to eat and meet and connect and talk to each other and socialize and enjoy this time. Anybody who wants to be served at their place, we do have lovely waiters and waitresses, so just sit at your place and we'll bring the food to you. Otherwise, please join the buffet.
Just wanted to let everybody know that because we started late, our team is requesting to shorten our lunch break to 20 minutes. So we will reconvene and start the afternoon session at 12:40. Please feel free to bring your lunches to your tables, and we are happy to speak as you continue to enjoy the meal.
You were here.
My great grandson is one of the pieces of house. I try to get to make a movie on it. Barry Levinson, remember Barry Levinson? So much. Really? He's my father's first cousin, my second cousin. You ever look the movie Apple? Yes, my mother's a little girl. She came from Thanksgiving to America. I didn't know.
We had someone that And when they do that,
Yes, sir.
Good afternoon. Notice by now that this incredible team runs on a very tight schedule. So our apologies that you had a few minutes to grab your lunch, enjoy a little bit of conversation, but we will need to get started. Much more information to share, excellent physicians and speakers to share their expertise with you for the rest of the hour. So please feel free to grab your lunch, bring it to your tables, and we will get started right now. Our apologies to everybody. Please get seated, grab your lunch, and bring it to your tables, and we will get started right now. Dr. Gordon Machado is an excellent speaker. He will be talking about the gut-brain connection and the role of the microbiome in Parkinson's disease health. Please sit down, get settled, and get ready for much more information for the afternoon session.
My name is Gordon Machado. I'll be speaking on the gut-brain connection Parkinson's, and just to allow us to remain on track with our schedule. So this is a good topic to discuss over lunch. So the first section, there's going to be two sections. The first section will be describing the gut microbiota dysbiosis in Parkinson's. So the pathophysiology of Parkinson's actually begins much sooner than the motor symptoms. So this chart shows that at time zero, where the gray bar are the early symptoms of Parkinson's, and you've heard of those: tremor, stiffness, slowness. Those symptoms are, the time at which we make a clinical diagnosis of Parkinson's disease. But now we certainly recognize that non-motor symptoms precede the onset of motor symptoms, sometimes by 2 decades. And then one of the very first ones that patients experience is constipation. They've done studies whereby they've looked at patients who have had, for example, a screening colonoscopy, and then years later go on to develop Parkinson's, and then going back to the colonoscopy samples, and then looking to see if there are some changes in those biopsy samples and in those colonoscopies, and indeed they found such changes. And what was found was a protein called alpha-synuclein. And alpha-synuclein is a protein that's important for cell-to-cell communication. So we all have alpha-synuclein, but in patients with Parkinson's, that alpha-synuclein phosphorylates or changes shape, changes three-dimensional shape, and starts to clump with one another, as shown in the bottom here. So alpha-synuclein begins to clump and form these larger proteinaceous structures called Lewy bodies. Once a Lewy body is formed in the cell is not able to clear out the Lewy body. It doesn't have a means to clear out, and dopamine producing cells are particularly susceptible to dysfunction in the presence of Lewy bodies, and that's what causes the cells to again become dysfunctional and ultimately make less dopamine and die off. So cells containing phosphorylated alpha-synuclein were noted to be present in colonoscopy samples, again, 2 decades before the onset of motor symptoms of Parkinson's. Now, this protein is thought then to actually begin in the gut. No, it's not. Oh, there it is. Okay. So the protein changes occur in the gut, and why that happens is due to inflammation, localized inflammation that occurs in the gut due to a gut dysbiosis. And this dysbiosis occurs secondary to constipation. So when a person's constipated, then they're not excreting waste, but also they're potentially allowing for bad bacteria to replicate, multiply, and lead to an overabundance of bad bacteria. And that's this concept of gut dysbiosis, where there is a change in the amount of flora of gut bacteria such that there's an overabundance of bad bacteria that result in inflammation, and that inflammation is what's inducing the changes in that alpha-synuclein protein, causing it to phosphorylate and causing it to clump. Once it clumps, then it starts to travel up into the nervous system via the vagus nerve and other nerves up into the brainstem. And so there's this concept of this gut-brain hypothesis of Parkinson's, whereby the changes of Parkinson's begin in the gut and then travel up to the brain proper. And the first part of the brain that's affected by this is it's the lower brainstem. This is advancing. Is the brainstem, so the changes of the phosphorylated alpha-synuclein travel up into the brainstem and then into the rest of the brain. The other pathway by which alpha-synuclein can exert a negative effect on the brain is through the olfactory bulb. So this gets to the concept of why is Parkinson's still the fastest growing neurological condition worldwide? It's due to environmental changes largely, because the genetic form of Parkinson's is only about 12.7%. So the vast majority of incident cases of Parkinson's disease are environmental in origin. And from an environment we're either inhaling through our nose or ingesting into our gut, the pathogens in our environment that then are inducing changes in these two areas, which are then conduits into the brain proper. Once it gets into the brain again, the dopamine neurons are particularly susceptible. So this shows a normal section, and we can see that dark substantia nigra, or black substance, where dopamine cells are produced. and that can be stained on this section of the brainstem. And so in Parkinson's, we see a paucity of that black substance, denoting that there's been loss of dopamine-producing cells there. This top structure shows individual cells. Each black dot is an individual dopamine-producing cell. And so with Parkinson's, again, there's a loss of a substantial number of cells. And again, by the time someone's clinically diagnosed with Parkinson's, there's 30 to 70% loss of dopamine cells in the substantia nigra. And this is a picture of a Lewy body. Again, this phosphorylated alpha-synuclein with proteinaceous material surrounding it. And here it shows the continued evolution of alpha-synuclein as it makes its way throughout the regions of the brain. So again, Parkinson's starting at the level of the brainstem, from changes down below at the gut, and then traveling up in the brainstem and also via the olfactory bulb and entering the brain that way. In mid stages, and these are based on neuropathologist named Brock, who developed this Brock staging system of Parkinson's. In mid stages, continued structures of the brain are involved with alpha-synuclein, and then in later stages, the alpha-synuclein has then traveled up into the cortex proper, and we see problems that some of which are already discussed with regards to changes in cognitive function, development of hallucinations and psychosis that can develop as the alpha-synuclein continues to travel up into the brain. So, one of the goals is then to better understand the changes that are occurring at the level of the gut, so as to prevent, if possible, these processes from happening in the brain. So let's take a deeper dive into analyzing these connections within the gut biota, dysbiosis, and PD pathology. So I mentioned that we're ingesting some environmental toxin. It's triggering the alpha-synuclein to become misfolded, constipation that contributes to or allowing for bad bacteria to proliferate and become greater in number. And these bad bacteria contain endotoxins, like liposomal material that then lead to breakage within the mucin membrane of our gut. And then those can traverse the intestinal wall and enter into our bloodstream and cause an inflammatory response in our bloodstream. And also get into our nervous system, the enteric nervous system, and create Lewy bodies that then travel into the brain. Now, these bad bacteria, Bacillus, Lactobacillus, Streptococcus, not only cause an inflammation in our guts, but also drive down levels of neurohormones like GABA, dopamine, serotonin. So in and of itself is going to have an impact on motor system and in our mood. And so, creating this degree of inflammation in the gut drives Parkinson's pathology, and also impacts even on drug absorption and vitamin absorption. So when medications may not work as well, or if patients have a misdose effect, they're taking the same dosage of medication, but it's just not working as well, the answer may not lie in adjusting levodopa, it may lie in actually correcting your gut function. And by that, I mean, looking at your upper intestinal tract, so addressing gastroparesis or slowness of stomach function, looking at your small intestine, and addressing constipation. In Parkinson's disease, our goal is for patients to have a bowel movement within 48 hours at the latest. If patients are going beyond 48 hours, then using interventions to limit that constipation from continuing on, because a normal bowel movement in those without Parkinson's would be about every 24 hours. So in Parkinson's, it's much more prolonged than that, and our goal is to have it within 24 hours to try to minimize these effects from occurring. So it's a vicious cycle that can occur in our gut, whereby we're ingesting toxins from our environment, resulting in gut inflammation, microbiota changes, increasing gut permeability, entering inflammation entering into our bloodstream and into our peripheral nervous system and up into our central nervous system through alpha-synuclein activation, entering up into the brain. And so again, what we can do down here in our guts can have a major influence into how significant a person's Parkinson's disease may become. So these are just some other diagrams to show that there are multiple steps along the way that we can take to help prevent the ultimate neuroinflammation that is occurring at the level of the brain. Now, there have been also ample studies to show that there is a specific, it's not just, when we talk about dysbiosis, we can be much more specific about the types of bacteria that are seen. So for example, what we see in abundance in Parkinson's disease is shown in blue, so lactobacilli is quite abundant in Parkinsonian gut. And what's seen in red is lacking. So Parkinsonicea is lacking in some of Parkinson's. So this is important as we think about even, for example, the use of a probiotic. So common probiotics over the counter contain lactobacillus. So using lactobacillus probiotic-based probiotic would not be helpful because Parkinson's patients already have an abundance of that. So you have to be mindful as to which probiotic you choose. The other aspect is by studying the types of microorganisms in our intestinal tract. A lot of research has shown that it can actually be predictive to the degree of Parkinson's symptoms and also the Parkinson's type. So, for example, there are some types of Parkinson's like postural instability gait disorder or traumatic Parkinson's. When they look back at stool samples and saying, okay, what is the composition of stool for someone with traumatic Parkinson's versus PIGD type Parkinson, the researchers can distinguish the two. And so it's gotten to the point that, there was a study published fairly recently that took stool samples of patients with Parkinson's and controls. And just by studying the stool, a person, the researchers were able to, with a specificity of 90%, determine did this person from which the stool came from have Parkinson's. So again, not even looking at the patient, knowing nothing about the patient history, just having the sample of stool in front of them, they were able to predict whether the person had Parkinson's and what subtype of Parkinson's a person has. So when we say every person has a different type of Parkinson's in terms of their symptomatology, our gut may be largely driving those changes. So in summary, these are the multitude of changes that can happen. So just to summarize, there's a gut dysbiosis with intestinal dysfunction, constipation, disruption of the effectiveness of our dopamine medications because they're not being absorbed properly, increased inflammation, increased alpha-synuclein, misfolding, which is then entering up into the brain via our vagus nerve and causing damage there. So what we'd ultimately like to do is, understand how to change this by introducing proper probiotics, prebiotics, symbiotics to improve our gut function, using the Mediterranean diet, introducing phosphophenols and antioxidants to reduce inflammation, a variety of changes that we don't have time to get into to improve our gut function, to ultimately reduce the possibility of alpha-synuclein creating further damage into our brain and central nervous system. And there's a lot of ongoing research now in trying to understand just how to do this. So thank you so much.
Oh, just an aside, I just want to add one thing, and maybe you'd like to know this. We just had a talk with Martha Carlin from Martha's Quest. And what she did, she did 20 years of research on the gut-brain microbiome, and they developed a product called BiotiQuest. And you could go to her website, marthasquest.com, and she makes her own probiotic that some people in our community are using, and they're finding it very successful. So I'd like you to know about that also.
All right, so my name is Dr. Mickey. I am one of the movement neurologists for Hartford Healthcare down in the Fairfield region. So my office is in Bridgeport, Connecticut. And I'm going to talk today about exercise. So this one I'm talking about, I'm going to start a little bit about talking about some of the research in Parkinson's and exercise. Then I'm going to get into the importance of exercise in the physical symptoms of Parkinson's as well as the non-motor symptoms of Parkinson's. Then I'll talk about what exercise to do, how long, and how to get started. So before I get started, can I just get a show of hands? Who exercises here? Who gets 2.5 hours of exercise a week? 2.5 hours. Okay. So this will be pretty easy then. So this is just a busy slide. The point is there are thousands and thousands of articles on the importance of exercise in Parkinson's. If you go to Google and you type in exercise and Parkinson's, there's. Is it better? Yeah. Okay. So there are tons and tons of exercises, and they have different studies based on the types of exercise, the length of studies, but there's endless research out there. I'll point that out. Thank you. All right. So as far as the physical symptoms of Parkinson's, the research has shown unanimously that people with Parkinson's that exercise compared to those that don't have an improved balance, have a reduction number of falls, have an improved grip strength, have a decrease in the wearing off. That's the symptoms of Parkinson's that return when the medications stop working. There's improved coordination, improved flexibility, decreased stiffness, and reduction in tremor. All this sounds fantastic, right? And you know, if I would be able to give you a pill to do all this, everybody would take it. But when I say that exercise can do all this, that's usually a little bit of a tougher challenge to get people to do it. The exercise is just as important, if not more important, than the medications we prescribe. So those of you that may know me or those that are my patients, I harp on this every single visit because it is absolutely crucial. On top of the physical benefits of exercise, as one of my colleagues had mentioned, there's a whole slew of non-motor symptoms of Parkinson's that for a lot of people are even more detrimental and more disabling on a daily basis than any of the physical symptoms you could ever have. And what the research has shown, again, is that people that exercise with Parkinson's compared to those that don't, or those that have minimal exercise, they have a reduction in depression, anxiety, improved mood, improved sleep, improved memory, improved quality of life, less constipation, reduction in daytime sleepiness, less blood pressure swings, and more energy. So a lot of things that we've already discussed today, exercise can take care of a lot of that. So we also have to remember that when you exercise, there are other benefits to exercise aside from Parkinson's. You know, even though Parkinson's is a component of what you have, you are much more than just Parkinson's. And the things that are really detrimental to patients with Parkinson's, a lot of times, is not even really the Parkinson's itself. It's the other conditions that come along, unfortunately, with aging. So the things that are great for Parkinson's also happen to actually prolong your life and are better for your overall health. So things like reducing the development of various medical problems. So heart attack, stroke, diabetes, high blood pressure, high cholesterol. You know, patients always ask me,
can I die from Parkinson's? And the unanimous answer we always tell people is you can't die from Parkinson's, you die with Parkinson's, with these conditions. So by exercising, not only improving the Parkinson's symptoms, you're also reducing the chance of developing these more dangerous conditions that are life-threatening. It also leads to weight loss and improved bone density. And we heard about the importance of bone density in Parkinson's. So I mentioned that exercise is important for people with Parkinson's, and there's really two kind of main reasons for that. The one is the immediate impact on exercise today and tomorrow. So it gives you the more energy, it actually improves dopamine production, but what's actually more important potentially than the immediate effect of the exercise is the long-term effect. So we do know that exercise has a neuroprotective effect. So although we can't necessarily undo the damage that's been done, what we have shown is that exercise can prevent the further damage of the neurons that are causing Parkinson's. So even if you're someone who never exercised a day in your life and you come to see us and you have X, Y, and Z symptoms, even exercising and starting that day will prevent the progression of your symptoms going forward. So it may slow down the progression. It can help restore some of the old connections that were lost, which one of my colleagues had mentioned that by the time you have physical symptoms of Parkinson's, you've lost up to 70% of your dopamine producing cells. As far as we know today, exercise is the only way to truly rebuild that and prevent the continued loss. So the question we always get is, okay, it's great, we need to exercise, but what kind of exercises should we be doing? And what I tell people is the what doesn't necessarily matter as long as you're exercising. The first step is to exercise. Because if you're not doing that, the type of exercise is secondary. But assuming you're already exercising or you have the ambition to exercise, the types of exercises vary from low intensity to high intensity. Some are better for coordination. So for example, ping pong, which some people may not think of as a form of exercise in the traditional sense, but studies have shown that ping pong improves coordination and hand-eye coordination. There's been a lot of studies on Tai Chi and yoga in Parkinson's, that the improved range of motion you get from Tai Chi and yoga is sometimes just as important as the medications that we take. So there's numerous different exercises, and it ranges from light exercises to moderate to more intensive exercise, and it depends on your skill set and your level of ability, but it can range anywhere from just simple stretching all the way to personal training. So how long do we exercise? So there's really no such thing as too much exercise as long as you're not hurting yourself. So there's no maximum. That being said, listen to your body. So if your body's sore, if your body's tired, that's too much exercise. But if it's not, and you want to do it, go ahead and exercise more. What we found though is 2.5 hours. That's kind of the gold standard per week of aerobic exercise. And it's important to use that term aerobic, because a lot of people will think that exercise is simply going for a leisurely walk. Aerobic means you're getting your heart rate up, you're sweating, you're out of breath. What I tell people is if you can have a full conversation with somebody next to you, that's not quite aerobic. So if you're going for that walk down the street, if you're going at a fast enough pace where you have to take pauses between your sentences, that might count as aerobic. But a leisurely walk that doesn't quite meet the criteria of being aerobic. Now it's not bad, and that's a good place to start. When we're talking about the true benefits of exercise, it's the aerobic component. So that's swimming, it's online exercise videos, it's Parkinson's boxing, Parkinson's dance, group fitness classes, personal training, or walking at a fast pace. That all embodies aerobic exercise. And what I want you to shoot for is 2.5 hours per week of aerobic exercise. In addition to that, so the components of exercise that are not aerobic are still very, very important. Now, they're not a replacement for the aerobic component, but they are a fantastic addition to it. So that's things like stretching, yoga, Pilates, Tai Chi, ping pong. These are the additional non-aerobic exercises that I tell people to do as tolerated. Getting started, in my opinion, is the hardest thing. So once you get started and you get rolling, it's a lot easier to continue it than when you've never done it or if you've taken a long pause. So I know personally, when I go on vacation, I come back, I don't want to exercise. And that time period off deters me from exercising. But once I get back into it, it's a lot easier. So first is get clearance. You gotta make sure that your heart, your joints are healthy enough for whatever exercise you're gonna do. Talk to your Parkinson's doctor about what type of exercise they think might be best for you as an individual based on your overall medical needs. Start small and work your way up. You're not gonna start from not exercising at all to doing 2.5 hours a week. That's the goal. You gotta build it up over time. And what I tell people is set small goals. So this week you do 30 minutes of exercise for the entire week. Next week you do 40, then 50, and so on until you get to whatever goal you have set for yourself, or whatever goal you have set with yourself and your physician. Take mini breaks. So if you're exercising and you're going for 30 minutes, it's okay to take a 5-minute break between that session. It doesn't have to be 30 minutes of straight exercises. Another easy way to get your exercise goal in is to set mini exercise sessions throughout the day. So if you're watching TV and you have an hour-long movie, maybe every 10 minutes, get up and do 5 or 10 minutes of aerobic exercise. Or better yet, put the stationary bike in front of the TV and pedal along while you're watching something and mix up the intensity of it. I find that finding partners, finding friends or colleagues makes it a lot easier because you can help each other become accountable for the exercise. When you're
And finding Parkinson's Wellness Project, where
Yes.
we have 6 classes a week.
And that's what the classes, I always recommend classes because it's helpful to be amongst other people. You're in and out, you don't have to do any thinking on your own as far as what do I have to do and how long do I have to do it for, it's all preset for you. A lot of times it's also built with Parkinson's in mind. So some of the limitations that people with Parkinson's have, it becomes easier to do one of these classes where it's preset specifically for you versus somebody who had a stroke versus somebody who has knee issues and so forth. Modify exercises over time. So one of the important things about exercise is it's not a one and done thing. This is something you're gonna have to do for the rest of your life. So if you get bored doing it, you're gonna burn out and you're not gonna wanna continue it. So you gotta modify it. So if 1 month you're doing an exercise class, maybe the next month you do a boxing class. The next month you do a high intensity class. Mix it up so you don't get bored of the same exercises over and over again. And then, there's a lot of classes out there. We have free wellness classes for any of our patients at most of our centers across the state of Connecticut. There's a lot of programs out there, both here and virtually as well. But the exercise classes are very helpful to kind of get you going. And that's all that I had in under time.
You did very well.
Can everybody hear me okay? Yeah. Okay, good. So using microphones. My name is Jeff Waterman. I'm I'm also a movement disorder specialist, one of my colleagues here. I practice in the Vernon location, one of our 3 movement disorder centers in Connecticut, obviously. So today, I wanted to talk to you all about food, nutrition, hydration, right, and Parkinson's disease. There's my title slide. So before I get into what's on this slide, I just wanted to kind of get into I kind of got a feel for it. That was kind of interesting. It's fine. So first off, just to give some general advice, right? We're always telling our patients, whether it's within neurology or general medicine, or maybe just telling your family members, eat food from all food groups, grains, vegetables, fruits in particular, right? And also to limit the intake of certain foods, all the good stuff, right? Salt, sugar, saturated fats, the fried food, the stuff that we have cravings for, right? But for Parkinson's disease, there's other things that can be provided in regards to information. For instance, I'm sure your physicians or family research really stress the idea of drinking lots of water. Depending on who you ask, it could be 6 to 8 ounce servings a day, or I heard one cardiologist say 2 gallons a day. Holy cow. To just have 2-gallon jugs in front of you just makes it seem like such a chore that I tell people don't really think about it that way. And I'll get into that in a minute, but also thinking about fiber-rich foods. And also think about, as I said, limiting sugar intake, limiting alcohol intake, and also evening caffeine, which sounds like a no-brainer, but you'd be amazed how many people like to have full octane coffee at bedtime. So another bit of advice is talking about weight in Parkinson's disease. A lot of patients with Parkinson's have trouble maintaining weight. And a lot of times it's unplanned. We think about, are you eating enough? How's your appetite? Is there anything limiting you from eating? Whether it's an involuntary movement, a tremor, a dyskinesia, even bradykinesia, moving more slowly, and just really not able to do that task, or the coordination of using utensils. And then thinking about also the ability to swallow. Unfortunately, some of our Parkinson's patients have trouble with that, whether it's an advanced stage Parkinson's disease patient or an atypical Parkinson's disease patient. And then there's the GI side effects that might get in the way too, whether it's nausea or some bloating. But the important thing is to maintain. Not just with Parkinson's disease, but you think about your immune system. Eating well helps fuel your immune system, so you won't be sick as often. And if you're not eating, you're not getting the nutrients you need, the nutrients that your body needs to function normally. Now, with that, there's also, my colleagues here have gone into the idea of doing things to not just help Parkinson's disease, but also your other medical conditions. So think about that too. So, there we go. Now, with weight, the concern, and first of all, nobody wants to talk about how much they weigh, right? Nobody. But Parkinson's disease patients commonly are asked, have you had reduced appetite? Have you had a drop in weight that you noticed over time? And if so, how much? Has it been an aggressive amount? Has it been just a few pounds? Because it varies. And one way to combat that is to make sure that we're adding foods with healthy fats. So nuts, nut butters, avocado, coconut, dark chocolate, fish, yogurt, tofu. That's half the reason I have these notes here, because I have to go through all the ingredients and the items and I can't remember them all. But also, as I tried to listen to the slide here, think about bitter greens, collard greens, beet greens, kale, mustard greens, turnip greens, broccoli rabe, radicchio, cherry, endive. I can keep going. But that actually will stimulate appetite. So does spicy food, which I'm not sure how people feel about that. And also from a gastrointestinal perspective, they can tolerate spicy food, but that's also something that actually can stimulate appetite. It actually makes you eat more. Now, touching on what I mentioned a minute ago, Also thinking about how you're eating or if you need to use any type of utensils. If you have a mixed type tremor, for instance, if you have a primarily rush tremor, but a little bit of a kinetic tremor component to it, think about weighted utensils, right? Think about rubber mats to secure dishes if it is maybe a dyskinesia or other involuntary movement that's getting in the way of you to kind of work the process of eating with what's in front of you without spilling. And then also for hydration, thinking about cups with lids and straws. You know, another thing to think about, which I know my colleague Dr. Bain was spending some time talking about, is exercise. Exercise increases hunger. So think about that way too, that we're able to kind of burn through energy to then take in more. And lastly, for this topic, think about eating more frequently, which makes it seem like a chore, right? But you're thinking about, all right, I'm going to eat every 3 hours, every 2 hours, or whatever it may be. But if you're able to keep to a regimen like that, as you would with your levodopa dosing, for instance, you might be able to stay on task with getting enough energy into the day. And that would likely mean that you'd have to eat smaller meals, right? Think of it as, well, maybe if you get in a big meal, great, but maybe it might be just a few extra smaller meals in between, or a few small meals throughout the entire day. So in my introduction, I did briefly mention hydration, and dehydration is very common. And it's not just among Parkinson's disease patients, it's also about among people as they age. If you talk to anybody over the age of 70 and you ask them how much water they're drinking a day, I guarantee you it's not the minimum that I mentioned earlier, right? And it's important to stay hydrated because we're thinking about our blood pressure, right? We're thinking about making sure we maintain our blood pressure, but also keeping it stable through the day. A lot of patients, as they live with Parkinson's disease, deal with orthostatic hypotension, or when they have drops in blood pressure when they stand, or in other instances, maybe when getting up from bed, and then they get lightheaded or dizzy, pass out, or even have other symptoms. Leg weakness, for instance, can happen common. But we want to make sure that we try in any way we can, without even taking medication, to try to prevent those symptoms, to prevent those episodes from happening. And other things also that's very relevant is confusion. A lot of patients, when they come to us, they'll say, well, I feel more confused, but it's episodic. I can't really tell when it happens. And you're like, well, what are you doing when you're confused? And they'll say, oh, I stand up and then I'm confused. I feel kind of out of it. That's probably associated with your blood pressure. So a potentially easy remedy is just drink more water. What's on my slide is also something important too, because a lot of times I get asked by a patient or told by a patient, it's easy for me to say, oh yeah, just drink 2 gallons of water a day. But I gotta pee, I don't know how many times during the day or during the night, right? Well, another way to approach that would be to think about the foods that you can eat that have a lot of water content. And actually by doing so, by consuming those things, you actually won't have as much of an issue in regards to urinary urgency or frequency. So what's listed on my slide, obvious ones: lettuce, celery, tomatoes, thinking about cucumbers, this is an obvious one. But then the radishes, broccoli, I was surprised when I read about that because I just didn't really picture them having a lot of water content. Squashes, anything with grape in the name, grapefruit, grapes, berries, pineapple, melons in general, especially watermelon, that's it in the name. And then lastly, think about how much caffeine you're intaking and how much alcohol you're intaking. People will then tell me, they'll say, oh, I drink, 6 glasses of liquids during the day, but half of it's tea. And I'll say, well, tea's actually dehydrated. So is coffee and alcohol. So those don't count. If anything, they kind of counterproductive, right? With hydration, we talked briefly about orthostatic hypotension, but there's also constipation. The drier you are, the worse your constipation will be. Now that picture is there to show you what you should not be eating and drinking. Sorry, guys. this is all the good stuff, but we have to stay away from that because it will worsen your constipation. We could make an argument though, based on this picture of what you see, that there's a high salt content. And you can say, well, that might actually help with retaining fluid. Okay, I'll give you that. But in general, those foods are ones you should be avoiding, especially as I know that for constipation, people definitely feel that to eat something like that. Now, to help combat constipation, the goal for fiber intake in a day is 20 to 25 grams of fiber a day. Now, everyone thinks about grains, sure, whether it's whole grain bread, even matzah, 3 grams per slice or sheet, but also think about the fruits, think about the veggies, they're rich in fiber, right, listed there. So kiwis, apricots, apples with skins, peaches, prunes, dates, raisins, figs, those are obvious ones too. And then for veggies, the ones that I thought that were interesting to mention would be cauliflower, onions, peas, and carrots. I don't think those are really thought of as often. I think it's usually those leafy green veggies as a source of fiber. And then also listed, as you can see, nuts, different types of nuts. In particular, the ones in the highest content would be almonds, cashews, pistachios, and walnuts. Beans is a given, and then I mentioned the grains as well. We'll get to that one. One thing that I wanted to also comment on, for another common symptom that patients with Parkinson's disease deal with is muscle cramping. And again, this ties into that whole concern about hydration. You have to stay hydrated. That will actually help reduce muscle cramps, whether it's during the day or night. In regards to supplements to help with this, obviously we talk about medications that can help with muscle cramping in Parkinson's disease that might be associated with dopamine loss. But thinking about supplementing with maybe turmeric, which is highly prevalent in yellow mustard. So maybe don't eat the hot dog or the hamburger on the other slide, but people must have other stuff. Then think about quinine. That's an old school remedy that everybody knows because they had to infuse tonic water with quinine. Oh my, I got that. So, and then lastly, increasing salt and vinegar intake, and that also could be with consuming pickle juice, which some of my patients have learned or read about online. Now, I am going to just go to this next slide now and talk about bone thinning. Common problem, Parkinson's disease or not. Parkinson's disease itself increases the risk for bone thinning. And it's important to maintain bone integrity and strength because we want to be able to have whatever advantage we can to move as well as we can. So think about meals rich in bone strength and nutrients. Those are the calciums, magnesiums, vitamin D, and vitamin K. Dairy is something that people always think about in regards to calcium, but they don't really think about the veggies or the types of fish, in particular canned or tinned fish, because those preparations actually are with seafood with bones that are edible, so it's soft bones. So, okay. And then touching on what Dr. Mayton was mentioning, walking and weight-bearing exercise is another way to help with bone integrity. All right. Now, I'm going to try to get through this next section relatively quickly, but the effect of foods on medications. How many of you in this room are on some form of levodopa? I imagine most, if not everybody with Parkinson's in the room. You always have to think about when you're eating, when you're taking medication. I actually tell patients not to really worry about that because it doesn't necessarily affect everybody in regards to protein. But another aspect to think about would be the GI issues. Thinking about the nausea that might be accompanied with taking levodopa, and usually having something in your stomach is helpful to help reduce that. But something that a lot of people are not aware of is iron-rich foods or iron supplementation can actually affect the absorption of levodopa. So the rule is avoid consuming iron-rich foods or supplements within 2 hours before or after a dose. Next medication I wanted to briefly mention would be MAOs, or monoamine oxidase inhibitors. In particular, The medications that are more used now would be selegiline or sagilin. There was a thought that MAOIs in general increase the amount of tyramine in our bodies. But that's actually not really a concern in regards to sagilin or selegiline, as they're selected for a certain subtype, right? So don't really worry about it, but just to go into it briefly, avoid tyramine. Well, I should say that people should be aware of what is being said about what not to consume when taking an MAOI. Avoiding leftovers, aged cheese, cured meats, liver, turkey, overripe fruit, certain other veggies like bananas, raisins, figs, and then pickled or fermented veggies as well. But the reason they warn people about this is for the MAOI-As, that subtype, or the general MAOI-A and Bs, which is the general inhibitors, is that it could cause surges in blood pressure. But with selegiline or sagilin, you really don't have to worry about it. So in case I just brought up to you guys by your doctors, you can let them know, all right? So then I just wanted to just quickly just touch on those medications and to then go into the idea of brain health and eating. Thinking about what can help with inflammation within the brain. So antioxidants is very commonly discussed, whether it's in media or among social circles. But the good part about antioxidants is they help convert food to energy. They protect our cells from stressors by capturing toxins known as reactive oxygen species. So that angry guy in the middle there in the red. And what those do is they can cause damage not just to the nerves, but basically to our whole bodies. They damage proteins, the lipids, the nucleotides. And because of that, we don't just get the nerve damage, but we also get essentially kind of breakdown of what surrounds the nerves. And because of that, the nerves don't conduct as well. Our bodies do not have the appropriate insulation and just don't fare as well. So antioxidants are help combat this by essentially trapping the reactive, the ROSs, or the free radicals, and then reduce inflammation. So antioxidants are very prevalent in purple and red fruits. You think of anything that's purple or red, that counts. Yellow and dark green veggies, especially leafy veggies, grains, nuts, in particular walnuts and pistachios, different seeds, whether it's sunflower seeds, flax seeds, and dark chocolate. So yes, you can eat dark chocolate. The other commonly discussed nutrient, or in this case fat, is omega-3 fatty acids. These fats help build cell membranes throughout the body and the brain. So not just the nerves, pretty much everywhere. But since it helps with nerve health, it does promote healthier brain cells and less deterioration and degeneration. Studies have shown that at least if you eat one seafood meal per week, you'll perform better with different thinking skill tests. So anybody that's going to go get a neurocognitive evaluation, go load up on some omega-3 fatty acids for multiple days. You'll perform better, okay? But it's not just the seafood though. It could also be, again, different forms of veggies. It could be the different forms of seafood, nuts, and seeds. Another form of fat that I just quickly wanted to mention, because I don't think it's really discussed nearly as much, but it is becoming more of a hot topic, are medium chain triglycerides. These fats help reduce inflammation in the body and also can help improve cognitive performance. There is some anecdotal evidence that can help with Parkinson's disease, motor and non-motor symptoms, which I know my colleagues have gone over. Where to find these types of triglycerides would be in any part of the coconut, whether it's the oil, the meat, or even dried coconut. And also avocados, seafood, full-fat dairy products, palm kernel oil, nuts and seeds. So with talking about the specific symptoms and medications and certain things to consume, then the next thing that's always asked by our patients is, what about the diet in general? What should you follow to make all this happen? I think that the preferred diet would be a Mediterranean diet, but it does vary from person to person. The main focus should be that it should be a plant-based diet, minimizing red meat intake, and really to promote a healthy fat intake. Right? So we do not want people to consume a lot of red meat, pork, but we do think about chicken, seafood, and that's not just for Parkinson's disease. That's with many other medical issues. And the limiting of protein, obviously can reduce the incidence of other medical conditions, but also think about the levodopa absorption, which I'm sure, many people have discussed about the timing, and I mentioned earlier that some people are affected by the competition of protein and levodopa being absorbed in the small intestine, but some people are not. But it is something to keep in mind. All right. Now, in regards to other diets, keto and paleo diets are mentioned. I would not recommend following those. They're highly restrictive. They're hard to follow because of it. And you actually might not be getting some of the key nutrients and ingredients that you actually need for your body and mind to be high functioning. So vitamin Bs, vitamin C, fiber, and minerals, you might be deficient. Also, when you're not getting those key nutrients, you might have worsening of other symptoms, whether it's your constipation or diarrhea. Now, with talking briefly about diet, I know we're on a time crunch. Supplements. Everybody always wants to know, what should I take or what can I take? I'm not a huge believer in supplements, to be honest. I think that it makes your food really expensive. Because you can only ingest so much, and your body can only absorb so much. So actually, with taking supplements, it's been shown that you're probably actually voiding or wasting off about 30% of what you will consume in a supplement, at least. So, and they're expensive. We actually do better in regards to consuming vitamins in the means of food rather than supplements themselves. We actually not only consume.
That's why we invite St. Lawn here today. All the food that you're talking about, we have
There you go. Good. I'm hoping that you didn't bring supplements. I'm sorry. There we go. But the point is that we absorb it better, we utilize it better when it's actually in food and not just in the capsule or pill form. So B vitamins are helpful in regards to metabolism and healthy nervous system. B1, B2, and you can keep going down the numbers if you like. But really think about B6 in particular, because it can actually reduce the risk of developing Parkinson's disease in high doses. But a caveat to that is it can actually reduce the absorption of levodopa too. So in moderation. So if there's other questions about other vitamins, you guys can approach me after, or we can talk about it during the panel session. If there's other questions about any sorts of ways that I can educate you guys about nutrition, please let me know. All right.
You would have noticed by now that I'm a little bit of a mother hen to this team of amazing physicians. I guess this audience doesn't know me as well, so I have to give my usual disclosure that I am an absolute crybaby. And when I look at these talented, skillful physicians sharing their Sunday with you, because they believe that education gives us the strength to muscle through and win over Parkinson's disease. That just touches my heart. So we at Hartford Healthcare's Chase Family Movement Disorder Center, we thank you for the opportunity to share this day with you. Our hope is that by being here today, this particular group of people will now see a little bit more of the whole iceberg and not just the tip. Because you have seen that many of the things that we know about Parkinson's disease is truly just the tip of the iceberg. There is so much more to learn, so many breakthroughs, so many opportunities that we have to have more control over all of the symptoms that are truly multi-systemic, multi-organic, that affect us all. Now I want to talk about a comprehensive center, because that is what we're really trying to portray and share with you right now. For a comprehensive center for movement disorders and Parkinson's disease to claim that they truly are comprehensive, their journey in building that comprehensive center needs to mirror your journey with Parkinson's disease. And that's what we have done at Hartford Healthcare's Chase Family Movement Disorder Center. You've heard the passion, the compassion, the expertise of these 9 physicians who are part of this team, everybody advocating for people, each person that we see. And we see 17,000 people in a year. We have 6 locations across the state of Connecticut, the closest to you being Bridgeport with Dr. Leon Maiden. But at each of these centers, the hundreds of people that we see every day, we consider ourselves partners in their journey. And in recognition of the fact that the program that we built is not just patient-centered, it's actually patient-driven. Because in the years that we have chosen to be in this career and care exclusively for people with Parkinson's disease and movement disorders, we have learned a few things ourselves. And we know that there are still so many unmet needs that our people with Parkinson's disease need care for. So the Parkinson's Foundation, which is a highly respected, highly recognized global advocacy group for people with Parkinson's disease, recognized Hartford Healthcare as the only global care network comprehensive care center in the whole Northeast. And that is in recognition of us having built this program with a bunch of services that mirror your journey. So let me tell you about what it might be like for somebody with Parkinson's disease to come through our doors and allow us the privilege of walking alongside you throughout that course of time. When together we can do the best that we can to manage each and every one of those symptoms and challenges and signs, limitations, and joys of living with Parkinson's. One of the best advocates for Parkinson's research right now is Michael J. Fox, and we are grateful for his advocacy for research. But I'm sure that you may have heard about his book talking about the benefit that having been diagnosed with Parkinson's disease has given him in terms of becoming a better person. So this is how we would like to partner with you in this journey. As you come through our doors, diagnosis is key. And you have the expertise of all of these physicians who have trained in excellent fellowships throughout the country to be the level of specialists that we are as movement disorder specialists. But in addition to that, we have also taken advantage of the fact that there are people who actually need more objective evidence. And just saying that Parkinson's disease is a clinical diagnosis and I'm going to make the diagnosis on the basis of your history and examination is not always enough for everybody in the room. So at Hartford Healthcare, we take advantage of the diagnostic tests that are available for Parkinson's disease right now. We do the most number of skin biopsies. It's called SIN1, and it's an alpha-synuclein detection test in the skin through 3 little pieces of skin samples that we take from the body. We also have the DAT scan, the imaging study that shows the loss of dopamine receptor transporters. And that can also help us with the diagnosis. But more important than that, you know what it is to have the diagnosis done at, with one of our physicians at the Chase Family Movement Disorder Center, is that we recognize that when we give that diagnosis, it is life-changing. And you will hear that we are making this diagnosis because we want to empower you. We want to give you as much education as we can. So the next step in this journey with us is to tell you about the support groups that we have going on, get you on the email distribution list so that you can take advantage of excellent educational opportunities through the Parkinson's Wellness Project and many other advocacy groups. We send you to our social worker who gives you a boot camp on everything Parkinson's disease. We would encourage you to see our specialized physical therapists, speech therapists, occupational therapists, because they too will give you boot camp for the physical activities and the right way to address the physical limitations of Parkinson's disease with very specialized programs. The traditional program is big and loud, but what we have developed is even bigger, is even better than that, a modified version of big and loud physical therapy and speech therapy, which is Power Up for physical therapy and Speak Out in Loud Crowd for speech therapy. In addition to this, you have heard us talk about naturopathic and allopathic and integrative medicine options, so that instead of journeying on your own to explore if there are supplements that are helpful for Parkinson's disease, we want to be your partner in that journey as well. Because what we have found is 60% of people with Parkinson's disease will explore these other options. We may as well help you navigate that and tell you, this one is nonsense, don't do that, that might actually be harmful. Let us consider this, let's consider turmeric, let's consider blueberries. So we want to be a partner in that as well. So we have a naturopath who is part of our program. We have an acupuncturist, a massage therapist, and we have wellness classes because you heard, exercise is key. So we don't want to just talk the talk, we want to walk the walk with you. So we offer Tai Chi, yoga, boxing, dancing, free of charge to our patients, to all our patients, because we don't want financial limitations to be the barrier for them taking advantage of this exceptional and very important part of their care. And then, of course, medications. And levodopa is still the gold standard of treatment. If you feel that your Parkinson's disease symptoms are still not well controlled, you need to be on levodopa. Levodopa is the direct replacement of dopamine, which is the deficient chemical in the brain for Parkinson's disease. And there are so many studies now that show that the way that we administer levodopa and the amount of levodopa that we administer actually will lead to people doing very well over the long term as compared to somebody who didn't start with levodopa. So it's about living your life to the fullest, despite this diagnosis. Actually, maybe living your life to the fullest because of this diagnosis, as Michael J. Fox has said. So if you are on levodopa, and now you're experiencing these other symptoms that can be challenging, the off time, on time, delayed on, random ons and offs, dyskinesias, involuntary movements. We have 33 medications for Parkinson's disease right now. And research is so strong. So every couple of years, another medication comes out for Parkinson's disease. And you heard Dr. Bortan say, we even have rescue drugs, on-demand therapy, this injectable that you can pop in very quickly if you're in an off state, and you go back on in 5 to 10 minutes, so that we can live our lives to the fullest because or despite our diagnosis. So anyway, there are so many things that we can do. The surgical options. So I'm just walking you through this journey, right? So people do very well with their medications, but then some other challenges come up. They may develop motor fluctuations, might develop dyskinesias. Know that we have something for that. In fact, the people that we see at Hartford Healthcare, I say this jokingly, but not necessarily all the time. Whatever it is that is limiting you, that is bothering you, that is important enough for you to want us to address, I have a pill for that. I have a pill for everything. The question is, do we want it? Do we need it? Right? So those are the decisions that we have to make. So now, if we develop behavioral health and mental health symptoms related to our Parkinson's disease, and that is limiting our ability to enjoy our day with our family because we're depressed or because we're having paranoid thoughts. We do have effective medications for that, but you have to share. You have to have that relationship with your physician that allows you to tell them about the things that are limiting. Because as we said, the only reason we are here as your Parkinson's disease physician and as your movement disorder specialist is to help you keep going, to help you keep doing all the things that you need to do and that you love to do for as long as we possibly can. So yes, so as Dr. Larman was talking about hydration and needing to pee, I got the bathroom signal, I have to run, have to go. You know, bladder symptoms, who talks about that with their physicians? Constipation, are you kidding me? I'm not going to tell my doctor I'm constipated, that I didn't move my bowels for, what did the Lord say? For 2 days, right? We have to move our bowels every 2 days. And if I'm on my 3rd day, I'm not going to my doctor that, but you should. Because constipation is a major symptom of Parkinson's. And you heard him say that that will alter the microbiome and make it detrimental for you to have all of those bad organisms as opposed to the good organisms that we need to do well with Parkinson's. So all of these things are things that you need to have the confidence to share with your Parkinson's disease specialist. And at the Comprehensive Center, as we have developed for you and for our people, what we have done is we have sought out specialists in dermatology for skin, endocrinology for bone, because we know that these are all important. Urology for the bladder, GI specialists for the gut, ear, nose, throat specialists for the anosmia and the swallowing difficulties. So we have found other specialists in other disciplines who will partner with us. And we know we'll have a special knowledge of different challenges beyond the tremor and the slowness of movement and the balance and the stiffness of muscles. Beyond all that, that we need their expertise too to help us address all of these multi-systemic effects of Parkinson's disease. So that again, what? So we can live our lives, so we can enjoy our days, so we can have control over Parkinson's disease. Symptoms further progress, and medications are no longer enough to control our symptoms. The surgical options are there. You've heard about deep brain stimulation surgery, groundbreaking, life-changing, an ability to reverse the clock by 5-10 years by addressing the off time, improving the off time, allowing people to enjoy their lives again because medications were no longer doing it for them. In addition to that, Hartford Healthcare has just acquired the latest technology in the management of Parkinson's disease treatment symptoms. high intensity focused ultrasound. There are a lot of people who would tell us, well, I realize that I need more help, and I probably am a good candidate for surgery because I'm not doing very well, but they're afraid of surgery. It is, after all, brain surgery. And of course, we try to remind people of all the benefits of surgery and the fact that we have an excellent surgeon who, compared to the national average of 4.5% complication, he has a complication rate with surgery of 1%. So we are very blessed. We have an excellent surgeon as part of our team. But for people who may not be a candidate for actual brain surgery, high-intensity focused ultrasound is non-invasive. So it's non-surgical way of creating a lesion in the brain that will pretty much mimic or equal the effect of DBS surgery. They just send those sonic signals through the skull, no cut, and the effects are instantaneous. Because with DBS, many of you know that after the surgery, we have to program. Sometimes it takes a few weeks to get the optimal setting. Sometimes it takes a few months. But with high-intensity focused ultrasound, the symptoms are controlled immediately after the procedure. So we have asked our system, Hartford Healthcare, if we can have this for our people. And now we are the first in the state and one of the very few in the Northeast who will have this technology, the latest breakthrough for Parkinson's disease and essential tremor. There are other things that you need to know. Parkinson's disease, until we find a cure, may progress. And at some point, the symptoms may be so challenging that it becomes unsafe for us to be at home. So we need home care. We need to plan for the long term. We need to think about what our wishes are, if there are any other options that allow us to continue to live the life at this level. And that is something that we also want to be able to share with you in terms of the journey. Because many physicians may feel that, okay, well, I guess it's how we're trained in medical school. In medical school, we're trained with the mindset of we always have to make things better, right? That's our whole purpose. We have to make things better. Sometimes there's only so much we can do. But at that moment, when we can't make everything all better, we are still not letting go. And that is something that I learned in the course of my career. I'm much older than all these other physicians over here behind me. So I've learned a few more things than they may have. But that was it. You know, that was something that was very important to me. When people get to the time when they are not able to care for themselves or their loved ones are not able to care for themselves, we need to be there with them at home. We need to be there with them to the very end. Palliative, hospice care is something that we talk about. Home care with home supplied physical therapy, occupational therapy, speech therapy, independence at home services, companions, caregivers, people that can drive with you, drive for you if you're no longer able to do so. So these are all things that we have integrated into this comprehensive program. Because again, our only purpose is to keep you going and to keep you living a life no less full despite the diagnosis of Parkinson's. So once again, we thank you for spending the day with us. It was a lot of information. Susan, you know we love you, and anytime that we have any opportunity to be part of this group and this community here in the beautiful Hudson, Westchester County of New York, then we are happy to be a resource for you as well. Thank you very much.
Hello?
thank you all for still staying with us and hearing our wonderful doctors. We imported them from Connecticut, and I think it was well worth it, don't you? We made a big trip, and we're glad that you all did. Thank you so much, because you speak from your heart, and we feel that. And I just want you to know, all the things that the doctors told us today, we feel hopeful that we won't have to get to that palliative point, because we're going to use all these tools that you're giving us, and everybody's going to put Parkinson's in the past, and we're going to live well and healthy. So that's what we want to see. We have to create good habits, right, Yaakov? You go to boxing twice a week with Yuri. We're creating good habits. We're connecting with each other. We have a women's care partner support group that is really wonderful. And we also have Simona, who comes from New Jersey and runs an amazing program at the Ridgewood YMCA, and the Nadbach is performing there on Monday. So we have a lot of things going on. We appreciate all your talks.